هذه آيات من الذكر الحكيم يرتلها الشيخ أحمد أبو العيني.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. سبحان الذي أسرى بعبده ليلا من المسجد الحرام إلى المسجد الأقصى الذي باركنا حوله لنريه من آياتنا إنه هو السميع البصير. وآتينا موسى الكتاب وجعلناه هدى لبني إسرائيل ألا تتخذوا من دوني وكيلا ذرية من حملنا مع نوح إنه كان عبدا شكورا. بسم الله الرحمن الرحيم. قل هو الله أحد الله الصمد. لم يلد ولم يولد ولم يكن له كفوا أحد. صدق الله العظيم.
صدق الله العظيم. We will display a short video put together by our marketing team in Moosa Hospital.
حسيت الزمن وقف لحظة يوم دريت إن فيني سرطان ثدي. يوم الدكتور قال لي ضاعت بين أفكاري لحظات كأنها سنين ما أدري شو أسوي. الدكتور تكلم عن خيارات علاج وأن في أمل وأشياء كثير ما سمعت معظمها. تأثرت، حزنت، يعني شعري بيطيح، يعني بيستأصلون شيء من جسمي. لكن بعد إنكار وحزن قررت أتعالج. اخترت أواجه السرطان. خضعت لجراحة ناجحة وبديت بعدها رحلة الكيماوي والإشعاعي. رحلة طويلة ولكنها مو بالصعوبة اللي تخيلتها. سهلها فريق الرعاية الكبير الشامل والأدوات والتكنولوجيا. كنت مطمنة وأنا بين رعايتهم ويدهم الأمينة. شهور ضحك ودموع وأخذات إبر لكنها مرت. أنا تعافيت. قصتي تشبه قصص كثير خافوا وترددوا. قصة فخر فيني وفي الفريق. أنا انتصرت على سرطان الثدي.
now it's time for ASH introduction, Moosa Healthcare Group introduction. Dr. Ahmed Antar, who's my partner in the oncology and head of the Department of Oncology, will give us a brief speech on behalf of ASH. تفضل أحمد.
Assalamu alaikum. So, dear colleagues, friends, ladies and gentlemen, good morning. I am pleased and on behalf of Moosa Health Group CEO, Mr. Malik Moosa, and the hospital CEO, Dr. Zainab Moosa, to extend my warmest greetings to everyone attending Moosa Breast Cancer Conference in Al-Ahsa. I would like to thank Moosa Health Group Academic Affairs and the organizing and scientific committee led by the chairman, Dr. Ahmed Al-Wabari, for their hard work and outstanding efforts to make this conference a great success. And I would express my sincere gratitude for the participation of the distinguished speakers and moderators who will make this event very fruitful in sharing knowledge and thoughts. And also big thanks to our partner in patient care, the pharmaceutical companies, Novartis, Stemline, AstraZeneca, and Gilead. So we witnessed in the last 2 years a remarkable expansion in Moosa Health Group projects. It started by the opening of the North Tower Hospital and our comprehensive cancer center, which includes all modalities of treatment from medical, surgical to radiation, oncology, and nuclear medicine services, is only one of the center of excellence in this hospital that includes neurology center, cardiology center, and orthopedic center of excellence. And more recently, Moosa Health Group opened a state-of-the-art rehab hospital. This hospital includes many rehab sections, musculoskeletal rehab, pediatric rehab, sport rehab, adaptive sport rehab, pediatric rehab, physical therapy, pain management, occupational therapy, hyperbaric therapy, and others, speech therapy and others. So furthermore, Moosa Health Group will have an amazing project in Al-Khobar. They will start the building of Moosa Health Group Hospital in Al-Khobar, in the Corniche Road. This hospital, in addition to our high standard and high quality of care, will have an extraordinary architectural design and location. So it's in the sea. So most of the patients will have sea view, and some of the patients will have sea view and Bahrain view. Moreover, this year, Moosa Health Group will start the building of Moosa Hospital in Al Hufuf. So it's another site of the city, also in this city. And a comprehensive primary care center that includes all general medicine, GS, pediatric, and OBGYN. So back to our cancer center, just recently we launched Moosa Breast Care Unit. So this unit includes a specialized, dedicated, providing exceptional care for patients, male and female, with benign or malignant breast conditions. So it includes a screening program, diagnostic program, from mammography to PET scan, from ultrasound-guided biopsy to stereotactic biopsy to MRI-guided biopsy, and the supportive of our expert pathology team, and of course, specialized medical oncologist and surgical oncologist with reconstruction surgery and plastic surgery, and the support of other services like psychiatry, psychology, nutrition, oncofertility, and rehab. So finally, I am sure we will feel enriched with knowledge after this event, And I welcome all of you once again to Al Moosa Breast Cancer Conference, and I hope that you will have a great time ahead. Thank you.
Shukran, Ahmed. On behalf of the academic affair, Dr. Abbas Mtair will have a couple of words. Please, Dr. Abbas.
Assalamu alaikum. Good morning, everyone. It's an honor to welcome you all to Al Moosa Breast Cancer Conference here in Al Moosa Healthy Group. We are very delighted to host this event in Al Moosa Healthy Group. We also wish to express our gratefulness to the organizing and scientific committee led by Dr. Ahmed Al-Wabari and Dr. Ahmed Anter, whose members have put together an engaging program, guest speakers, moderators, and attendees. Well, back in November 2022, we had the first International Oncology Conference, which was conducted here, and also an attendees of almost 300, who also suggested in their views to have a specialized programs like on subspecialties, like for example, the breast cancer. Here we go. And we also, at the level of the academic affairs and the oncology center, we have a Al-Ahsa hematology oncology club, which is regularly being conducted every 2 months with an attendees of an average 30 attendees get involved in the discussions being conducted in the Al-Ahsa hematology oncology club. I sincerely hope that you will enjoy the 2 days of training and discussions. And before coming to the close of these remarks, I would like also to express my sincere gratitude to our health group CEO and Al Moosa Hospital CEO for their endless support and encouragement. Thank you for your attendance, participation, and also support. Thank you very much.
Well, we'll start our academic agenda, and the first talk will be Challenges in Breast Cancer, moderated by Dr. Hamid. Please, Dr. Hamid.
Assalamu alaikum and good morning. We will start our conference where the story starts with a pathologic diagnosis. Our speaker today is Dr. Miral Mashhour. Dr. Miral is a senior anatomical pathologist, subspecialized in breast and gynecologic pathology at Sunnybrook Hospital, Toronto in Canada. She is currently the chairman of the head She's the head of the Department of Pathology and Laboratory Medicine in King Fahd Specialist Hospital in Dammam. She has presented many talks in local and international conferences, and she published many articles in the pathology area. Welcome with me, Dr. Miral Mashhour.
Assalamu alaikum. Good morning, all. Thank you, Dr. Hamid, for your kind presentation, and thanks to Dr. Al-Wabari for the invitation. And thanks to the academic affairs at Al Moosa Hospital for the very well organization and of the transportation and organization of the conference. Thanks to all audience for attending actually really early morning Friday conference. And without any further ado, I have to start my presentation, which is challenges in breast cancer pathology. It's not moving. This one? Yeah? Ah, okay. Oh. In the edge? Ah, you know, okay. This is next. This is next. Okay. So next slide. Next slide. Next slide. Okay, thank you. Yeah, so this is my disclosures. I have no disclosure. And I always like to start my presentations with the take-home message, because this is the most important message that I want to give all the audience from my presentation. So the take-home message is the multidisciplinary teamwork is very important when it comes to treatment and tailoring the treatment for breast cancer patients. And I consider our breast team is a very strong team at King Fahd Specialist Hospital in Dammam, where we all discussed all cases, challenging cases, new cases at our breast tumor board. Our breast tumor board is usually every Monday, and we discuss up to 16 cases per tumor board. The least number of cases that we discuss is 10. It starts at 12, and sometimes it ends at 2, and this tells you the importance of MDTs in the tailoring of the patient care. When it comes to pathology, also the most important thing that I want to discuss here is the path-RAD correlation. Path-RAD correlation is very important. I encourage all pathologists not to report any case without discussion with the radiologist, even prior to the tumor boards, because many cases can be resolved, with the path-RAD correlation. So talking by phone, or even you go to the radiologist and discuss it one-to-one will help a lot our patients. So the challenges when it comes to pathology or reporting of breast cancer, I have to tell you that there are lots of things before the slides comes to us at our desk. We have many things that you should take into consideration before reporting any breast case. We have the pre-analytical factors that will affect our slides, and we have the analytical factors, and we have the post-analytical factors. The post-analytical factors are the only factors related to the pathologist himself. I mean, the competency of the pathologist, the experience of the pathologist, and it's all about, the post-analytical is all about pathologist. But before pathologist, we have the pre-analytical, which we face a lot of problem when it comes to referral cases, because we don't know anything about the fixation, the ischemic time. So really we face lots of problem when it comes to review of cases, and I'll show you a very nice case documenting this. The analytical depends on the technologist himself. How experienced is the technologist? He should put his positive and negative controls for us in this slide. So the analyticals depends on the technologist himself, plus the equipments that you have. At King Fahd Specialist Hospital, we have the two immunohistochemistry machines, which are the Ventana and DACO. So when it comes to pre-analytical also, it depends on the quality of the biopsy that was given to us. So you don't know the needle went where. So the radiologist will tell you that I'm sure, and actually sometimes in the tumor board, the radiologist will show you, look, my needle is inside. And then you are telling me it's inadequate or it's a benign, and to me it's a malignant. So you don't know where your needle went, and you don't know whether, while taking the needle out, maybe you did not get any tissue. So I want here to confirm that we pathologists report what we see. We have a slide, we have a tissue, we just report what we see. We are not magicians that we are reporting something that we cannot see, okay? So, of course, when it comes to the tissue, they always say tissue is the issue. Yes, if you give me a good quality cores, like when it comes to breast, if you give me 4 big, nice cores, yes, you will have a decent report. But if you give me a very tiny biopsy, like less than 0.2 centimeter in diameter, and you are telling me that I am sure this is BIRAT 5 and I'm sure I'm inside, you wouldn't get a decent report. So I'll start with some of our very interesting cases that we got. Some of them were published already. So I'll start with case number 2, and this case is Dr. Wabari's case. Actually, I know all the cases and the oncologist who saw this case. So this was Dr. Wabari's case, 23 years old female with a right breast mass, was given BIRAT 5. BIRAT 5 يعني malignant. So this is the course that we get, and see it's a very excellent core. You can see the core up, and you can see this is part of the core down. So it was an adequate core, and you see infiltration. You see this black cells. There's infiltration by a tumor cell, and you can see very nicely the ducts here at the right side are compressed, and there is infiltration by this malignant cells. In the first glimpse, maybe you'll say that this is invasive lobular because the cells are discohesive, but it's not actually invasive lobular. So this is a more high power field to see this infiltration by this malignant cells that are having hyperchromatic nucleus, okay, and a little bit of cytoplasm. This is even more high power field of the tumor, okay. So it's a high-grade tumor, poorly differentiated. You cannot see tubules. So the next step is that you will do immunoprofile. Actually, this case, the radiology was only for the breast, okay? So this is the ER, and as you see, the ER, it's positive. The positivity is brown, but it's weak, and it was labeled, given as 90% ER positive, okay? This is a stain that is strongly positive. I will not say this, which stain is this, but it is strong, diffuse, and it's nuclear positive. And this stain is also positive. This is a negative stain. Okay, so this case was released as invasive ductal carcinoma, grade 2, and it was ER, it was labeled as ER positive, weak, 90%, PR negative, HER2 negative, and KI was labeled as 10%. So it was luminal what? Luminal A breast cancer, okay? So then, liver biopsy was obtained for this patient, and another pathologist reported it as metastatic lung carcinoma. He did all the breast markers, and they were negative, and TTF1 was positive. So I got a phone call from Dr. Wabari. Miral, what's going on? This patient has 2 primaries. She has breast luminal A and lung metastasis to the liver. So I went back to the breast biopsy, and I did more immunos. So this is the first immuno I did, and this is napsin A. Second immunos that I did, and this is TTF1. So TTF1 is strong, diffuse nuclear staining, and napsin A is positive, okay? So don't be fooled by ER positivity, as lung cancer can be ER positive, but ER positive is usually weak. It's diffuse but weak, like our case, exactly. This is I will not go through the scans and the echoes, and so the diagnosis was a metastatic polydifferentiated adenocarcinoma of primary lung origin. She's 23 years old. And so she started the first cycle of taxocarbo on 25th of August, 2021, and unfortunately, she passed away on 4th of September 2021. Actually, I got the NGS report and was happy and called Dr. Wabari and told him, okay, she has, it came positive, but unfortunately the report came after the patient, passed away. Case number 2 is a 51 years old male patient presented with a right breast mass by RAD5 with skin lesions. So the lesson learned from the first case is not always breast masses are primaries, so you have to put in mind that metastasis can happen also in breast. So this is the clinical, this is the skin lesions, how it appears for this patient. And this is the biopsy. Actually, this is a case of the oncologist is Dr. Leo. So you see here the infiltration up by discohesive small cells. This is a more high power field of this discohesive cells with plasmacytoid-like feature, eccentric nucleus, and plenty of eosinophilic cytoplasm. This is even more high power field. It's a very nice and beautiful, actually, tumor to see under the microscope. So, and then it was ER, it was triple negative. I have to go back. No, back. It was triple negative, and androgen was 90%. It was positive strong, 90%, and KI was 40%. You see the positivity here at the end is 40%. So the diagnosis is a polymorphic lobular carcinoma in a male patient, which is extremely rare. We did PD-L1 testing here by Ventana SP142, and it was negative 0. This is the patient. You can see the lesions are very nicely after 4 cycles only of tax and the chemo. See, as you know, all of the skin lesions more or less disappeared. And I'll just give you a little hints about polymorphic lobular carcinoma. As you know that lobular carcinoma in male breast is extremely rare because they don't have, the male breast doesn't have lobules. And being a polymorphic lobular is even more rare. And polymorphic lobular carcinoma was first described in women by Dixon in 1982, according to the World Health Organization classification, is defined as it is a variant of lobular breast cancer, but it acts and it looks polymorphic and very aggressive, like the ductal type. Molecularly, it's the same as lobular, and polymorphic lobular carcinoma of the male breast is extremely rare, as I told you, occurs being only, this is the 9th case report in the literature. And invasive lobular carcinoma of male breast was first reported in 1986. There are some risk factors like BRCA2, CDH1 germline mutation, hyperestrogenism, and testicular dystrophy, radiation, and it's more common in Ashkenazi Jewish. Of course, as any lesion, and I told you that you have to really rule out metastatic tumors before calling it polymorphic lobular carcinoma, as it's really extremely rare. So here we are reporting an extremely rare case. So the lesson here is that lobular carcinoma can happen in male breast, and breast cancer, of course, is rare in male, but it happens, and you have to keep your eyes wide and do all the necessary immunohistochemistry to confirm your diagnosis. Case number 3 actually is a nice case, and it gave us a lesson, but the hard way. 70 years old female with bilateral breast masses. So this is the mass, and as you see, there's infiltration by this cohesive cells also. Again, this is the high power field. You see that the cells are this cohesive. Full cell is lying separately, and you can see here, you can be sure that this is malignant because it's infiltrating the fat. These empty spaces are fat, so there is here. This is more high power field. When you look at it, the first look, the pathologist will look at this, he will think that he's looking at histiocytes because there is plenty of eosinophilic cytoplasm and there is infiltration of the fat, so you think that this is histiocytes. So immunos were done, CD68 was done and it was negative, and HER2, as you see here, it's blue. Blue means negative, and this is the Ki67. You see, Ki67 is positive, and it's really high. It's about 30%. So it is a it's a triple negative with high Ki67, ECAD negative, CD68 negative. So the diagnosis is, pathologist diagnosis is invasive lobular carcinoma, histiocytoid variant, and it's triple negative. We have published a case of, with Dr. Wabari about this histiocytoid variant that are triple negative because, as you know, that lobular is usually luminal A, ER positive, PR positive, but this was a triple negative. Then she took chemo, and then they did mastectomy. So this is the mastectomy post-chemotherapy, and this is the residual tumor. Do you think the residual tumor looks the same as the original tumor? No. Here you see that the nucleus is hyperchromatic and eccentric nucleus and very distinct eosinophilic cytoplasm. So this case was diagnosed in 2022, Feb. Then the patient came with axillary lymph node. So this is the tumor in the axillary lymph node, the same axilla, okay? So what do you see? You see infiltration by the same tumor that we saw post-neoadjuvant chemotherapy, and then this is HER2. So HER2 is positive 3+. So the lesson learned here is that if you see actually we used to do, to repeat the immunoprofile post-neoadjuvant, but we stopped that. But if you see a tumor, actually the tumor in the post-neoadjuvant mastectomy showed that it's a polymorphic type, which is more aggressive than the histiocytoid classical type that was diagnosed in the biopsy. This should provoke you to repeat the immunohistochemistry on excision. Unfortunately, it was not repeated, and then I got the call from the oncologist, Dr. Leo. Miral, can you do the immunostains in the mastectomy specimen? By the way, Miral, the patient is refusing to take any chemo, but we just do it to see. And yes, I repeated the immunohistochemistry. It's the same, ER, PR negative, but HER2 was positive, and it was nicely positive in the polymorphic type of lobular carcinoma, and in the classical type, it was negative. So this is the lesson learned here, that if you have a triple negative in a biopsy, especially if the biopsy is a referral case, you repeat the immunoprofile on the excision. The case number 4 is an 84 years old female with right breast invasive ductal carcinoma. This is a referral case, and it was diagnosed at the referring hospital as invasive ductal carcinoma for histopathology review and sent back for referring surgeon. The lesson learned here is don't underestimate the surgeon. The surgeon knows a lot when it comes to radiology, so the surgeon did not like invasive ductal carcinoma after seeing her radiology. I started with the immunohistochemistry. I have to tell you that when I was a fellow, my supervisor told me that diagnosing breast cases are usually on scan. And she's absolutely right. Because in scan, if you look at this, you see that it's mainly lobules and tubules. And yes, there is something, eosinophilic in between. And if you look here, yes, there is what appears to be necrosis or infarction. Here it looks more towards infarction. So this was called invasive ductal carcinoma grade 2. Immunoprofile was not done because they don't have immunoprofile at the referring hospital. So when it came to us, we just did, looking at scan, it's not invasive ductal carcinoma at all. It's not malignant at all. So we did only one single stain, which is very important and vital, which is a myoepithelial marker, which will tell you this is invasive or DCIS. It doesn't even look DCIS. So this brown stain was beautifully positive, taking all cells. So the myoepithelial cells are there. So it was called, the diagnosis is adenomyoepithelioma. Adenomyoepithelioma is completely benign, so the treatment is completely different. And the patient is 84 years old. She's old, and she doesn't need this aggressive treatment. So immunohistochemistry here is very important, and as I told you, the scanning is very important. The experience of the pathologist is very important, and actually the case went back to the referring hospital, and the surgeon did only excision with a safety margin for this case. And it was referred back to us. Actually, I'm waiting for this case. I didn't receive the slides yet, or I should have, showed it to you after the excision. But after the excision, I got the report from the referring hospital, and it was called adenomyoepithelioma. Okay, this is the last case. Is a 66 years old female, new case of breast cancer. Slides for review. Mastectomy was done outside. And this is what we got. This is a beautiful, actually a very beautiful case. This is a case of Dr. Leo. And as you see here, that you can see glands and mixed with squame, okay? Here, I think maybe here is better. You can see the glands very nicely formed, and in between you can see here up and there the squame. So this is the stains P63 and CK56, which are squame markers. And this is a metaplastic carcinoma, low-grade adenosquamous. And actually, Dr. Liu, when he called after hearing the diagnosis, he said, yeah, this is very good and prognostically good for the patient, and it goes with her clinical. She has been having this mass for about 3 to 4 years. So adenosquamous is not a common diagnosis, and sometimes you see it with these benign lesions, papilloma, adenomyoepithelioma, radial scar. You can see these benign lesions, and beside them you will see the adenosquamous low grade. It has an indolent course with a favorable prognosis. Lymph node metastasis and distant metastases are rare. Our case is very peculiar. Usually, as you all know, that metaplastic carcinomas are triple negative, but this case was luminal A. It was ER 70%, PR 30%, and KI was 10%. Okay, so I'll just end my presentation with the latest updates regarding the HER2 testing. And as all pathologists know now, that we have to report the HER2 low positive cases with a comment, and this is what we are doing now. Actually, I don't release it as negative score 1+. I just release it as a score 1+ with the comment that this is considered low positive, and it's entitled for drugs. And thank you for listening.
Thank you, Dr. Amiral. That was very, very interesting cases, and I enjoyed the presentation. Do you have any questions for our speaker? Audience. Yeah, maybe we don't have pathologists.
Dr. Miral, just here, please. Hello. Just clarification about the last case. So, metablast, is this a subtype of metaplastic carcinoma? It's not the usual metaplastic carcinoma.
It's a subtype. You know, there are different types of metaplastic carcinoma. We have the fibromatosis-like, we have the squamous type, we have the adenosquamous low grade.
The usual metaplastic is more aggressive and tend to metastasize,
Of course,
right?
yes, and it's usually triple negative.
Okay, thanks.
Marwan, mic there, please.
Excuse me.
Thank you, Dr. Miral. Excellent presentation. What's your take? You mentioned something about retesting the immune stains after giving neoadjuvant therapy. Do you have any recommendation? Because sometimes I do it when I have a weird tumor that I suspect that they will have complete response and I see some disease left over. But what's your take on that and what do you suggest?
Actually, we used to do, we used to repeat all profile post-neoadjuvant, but due to financial issue, we stopped doing that. We spare this upon request from the oncologist. Sometimes I get a phone call from the oncologist that please repeat, the immunoprofile, and I do it when I find a very aggressive subtype that was not seen in the biopsy, like this case. Actually, this case should have provoked the pathologist to repeat the immunoprofile because himself he wrote in the diagnosis it's an invasive polymorphic type and classical type lobular. Sometimes we get excision, we get a biopsy from for review from an outside hospital and it's triple negative. For me, I try to repeat these cases. More or less, these are the cases that we repeat the immunoprofile. Triple negative. But positive cases, if the case is triple positive, why repeat after a neoadjuvant? So we don't tend to repeat these cases.
A comment, not really a question, about the case that Miral presented. What made us repeat or review the pathology is that from a medical standpoint, it doesn't make any sense to have a T1 N0 with brain and liver metastasis. So it just didn't make any sense. It was triple negative. But I told Miral that I'm just not comfortable with this. You have to review it yourself. And when she reviewed it, it was lung cancer. Unfortunately, the patient did not make it beyond a couple of weeks, 23. It was a very sad story. But the moral from the story is that what doesn't make sense clinically should be re-evaluated with the pathologist.
A comment, guidelines for repeating or not in the College of American Pathologists, one of the indications to repeat is you feel not comfortable. So it is subjective. You can repeat any negative one.
Perfect. Well, thank you very much, Dr. Hamid. Thank you, Dr. Amiral. It was really very nice talk, and we will have to move on. So thank you very much. So we will have a couple of satellite symposium and in an orthodox way. So the first one will be presented by Marwan Al-Hijali. Dr. Marwan is the chairman of internal medicine at King Abdulaziz University, who will lead the next session. Fadal Marwan.
Bismillah, salatu wassalamu ala Rasulillah. Thank you, Dr. Ahmed, for the introduction. And I thank the Moosa group actually for organizing this meeting and having everybody coming together to talk about a very important subject in oncology, which is breast cancer. It's my pleasure actually to be moderating the next workshop, which is sponsored by Novartis. And it will be about the Ease and Empower Together CDK4/6 Inhibitors Mastery class. So we will kick off with a video. Yeah, as usual, that's part of the video, by the way.
Women are a hapless society, and we deeply recognize their organ-driven role. Without active involvement of women, our ambitions will remain incomplete. Together, we possess the extraordinary ability to shatter barriers, achieve success, and extend our reach beyond. Today, Novartis proudly unveils a groundbreaking workshop dedicated to empowering healthcare professionals. We aim to provide HCPs with the knowledge to offer unique care for breast cancer patients. Our goal is to arm them with necessary guidelines, ensuring a deep understanding of treatment protocols and best practices. Join us to understand the best management approaches.
Right. So this is the topic of our workshop. It will be 1 hour, and you know, for all workshop, we need the participation of all the audience. And for that reason, I think everybody should scan the QR code for now, so we can answer all the questions that we'll have along the presentation. Okay. So this is the code, and I hope everyone actually can scan the screen for now and have the website ready on their phone so they can answer all the questions that we will have along the presentation. Our workshop will be 1 hour, divided into 3 talks, 20 minutes each, and it will have 1 scientific talk and then 2 case presentations. Due to just some inconvenience for our off-site presenters, we will start actually for now with the case presentation. Come up. Oh, okay. Sure. Okay. All right. So it's my pleasure actually to introduce Dr. Ahmed Al-Rifai. He's a colleague and a friend. He's the founder of the Oncology Private Club in Jeddah, and he will be actually presenting a case for us in breast cancer. Dr. Ahmed.
السلام عليكم. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. First of all, I would like to thank the organizing committee, Dr. Ahmed Al-Wabari, for their kind invitation. And I would like to thank Novartis for just inviting me to be with them in this satellite symposium. So just we are speaking about how to empower the precision medicine and how to just select the proper treatment for our patient with hormone-positive breast cancer. And one of these tools is just to know exactly what is the toxicity profile of our medication. We have 3 molecules in the CDK4/6 inhibitor. Just if we just look at this busy table, we can find that in these phase 3 clinical trials, the most common hematological malignancy is neutropenia, anemia, and thrombocytopenia. Neutropenia is more common with abemaciclib. It takes place in about 70 to 80% of the population, usually grade 1 and grade 2, and the grade 3 is still high, about 50 to 70% with the palbociclib and ribociclib, while with abemaciclib is much less. It is less toxic to the bone marrow, and the grade 1 and grade 2 is about 40 to 50%, and the grade 3 is much less. While the anemia and thrombocytopenia is in the 3 agent is really mainly grade 1 and the grade 2, swinging around the 20%, more common with palbociclib. If we look at the non-hematological malignancy, we can find diarrhea. Diarrhea is really very common with abemaciclib. The grade 1 and the grade 2 take place in about 80 to 90% of the population. So most of the patients will have some sort of diarrhea. The grade 3 and 4 is only 10%, while the diarrhea with palbociclib and ribociclib is much less, around 20 to 30%, and rarely to find high-grade anemia. What about transaminase? Transaminase is more common with ribociclib, and with abemaciclib is around 15%, while with palbo is much less. And finally, the QT prolongation, which is peculiar to the ribociclib, it takes place in 5 to 10% of the population, and usually it's of low clinical effect. What about quality of life? In those metastatic patients, quality of life really matters, because if we will not achieve cure, so we have to take the quality of life seriously. We can find in the all clinical trials there is no deterioration in the quality of life, and rather there is some improvement in the Mona Lisa 7 and the Paloma 3. Can you change? What about the quality of life from the patient perspective? Really, the patient perspective differs from the healthcare provider perspective. So if we look at this, we can find that 83% of the population, they will have some sort of moderate to severe side effect, at least one or more of these side effects. And most of these side effects, which the patient think it affects their quality of life, is including the fatigue, the low sexual interest, loss of appetite, back pain, hot flushes, and anxiety, diarrhea, and insomnia. And when they just made survey with the patient, which one of these side effects which impacts the quality of life, you can refuse the medication because of this side effect. And if we look at the table on the right side, they found that almost 60% of the patient can refuse the medication because of the possible impact on the quality of life. So the tolerability of 50% of the patient to the back pain is really is minimal. They just refuse to take the medication because they're afraid of the impact of such side effect. And how to compare between the medication? Actually, so far we don't have a head-to-head comparison between this medication. So the only solution is just to do match assisted in direct comparison between this medication. And when they made it regarding quality of life between the ribociclib and abemaciclib in the Mona Lisa 2 and the Monarch 3, they found that really ribociclib is doing a better result regarding quality of life, regarding diarrhea, fatigue, and appetite loss, and the arm symptoms. So let us go for one of the real case. She is a 71 years old lady. She has diabetes mellitus and hypertension. Patient just came as a consultation from the internal medicine. as a bedridden patient with generalized bony aches and poor food intake, patient ECG performance 3 or 4, and with large left breast lump more than 5 centimeter. And just the imaging showed the presence of it showed metastasis in the whole skeleton, as you can see, and there is a pleural metastasis with pleural effusion, and there is liver metastasis, as we can see in the PET scan. And just a biopsy revealed the presence of IDC grade 2, ER and BR strongly positive, Ki67 28% and negative for HER2 new. And the baseline CA15-3 was 518. So for this patient, really, we were just reluctant to start for her treatment, being very poor performance status, and just finally we said just we can go for some sort of, the lowest possible hormonal treatment with aromatase inhibitor. We offered the patient letrozole, and after a couple of weeks we did the tumor marker. We find the tumor marker is still rising. So by this time we don't know what to do, and we just suggesting doing feeding gastrostomy for the patient to improve her general condition, and we added for her one CDK4/6 inhibitor. Really, we were thinking which one. If we offer abemaciclib, it can increase the loss of appetite, the diarrhea. Patient was bedridden and using napkins, and if we offer palbociclib, also the bone marrow depression and neutropenia, she has a baseline neutropenia. So we just elected to go for ribociclib 600 milligram. And here, as we can see, patient has chronic neutropenia, and when we added the ribociclib, patient showed grade 3 neutropenia. So what we have to do? So what is the time usually for the neutropenia or to happen? Usually about 2 weeks, and the median time for resolution is another 2 weeks. And regarding the QT intervals, it needs also 2 weeks to show up the prolongation of the QT. Regarding the hepatobiliary, it can take up to 2 months to see the hepatotoxicity, and for recovery, it needs about 4 weeks. So if abemaciclib was used instead of ribociclib, what are the most common side effects expected? We have here diarrhea, neutropenia, liver toxicity, ILD, VTE, and the QT interval. So there will be answer, or? So please, can you scan the QR code and just answer the question? Can you show the result? So as you can see that the result is just going with diarrhea, which is the correct answer. As we mentioned, about 80 to 90% of the patient will get some sort of diarrhea. So how to manage the treatment side effect? As we can see, we mentioned that neutropenia is a very common side effect with CDK4/6 inhibitor, and if we just try to make it ranking from the highest to the lowest, it started with palbociclib and ribociclib ranking number 2, and finally the abemaciclib. If we check the febrile neutropenia, it's really very, very seldom to happen with CDK4/6 inhibitor in spite of the very low neutrophil count. It's not like chemotherapy, and you can find neutrophil in febrile neutropenia. It occurs like 8 in 1,000 with abemaciclib, and 23 in 1,000 with valbocyclib. How should we manage the neutropenia? Actually, for grade 1 and grade 2, we can do nothing, just to continue on the same dose. And for grade 3, just we can withhold it till the recovery to less than grade 2 and then resume at the same dose if recovery took place within 1 week. And if it is more than 1 week, we should do the first dose reduction. For grade 4, usually we should hold till the patient recover, and then we start with the lower dose. And regarding the ILD actually is very rare, but it is real. As we can see here, it is significantly occurred in comparison to the placebo from 0.7% to 1.6%, and it is the highest with abemaciclib, 2.1%, and very, very, very rare with ribo and valbocyclib. And just for the ILD to take place, usually it takes up to 2 months, and with abemaciclib, and about 8 to 9 months with ribociclib. What about diarrhea? As just mentioned, diarrhea is very common with abemaciclib, and it is 1/4 with valbocyclib, and the grade 3 is 1/5 the abemaciclib regarding the ribo and the valbocyclib. And the grade 3 is really very rare to happen with ribo and with the valbo. What is the time for diarrhea to occur? Usually for grade 1 and grade 2, it's about 10 days. For the high grade, it is about 7 days. And still, there is other GIT symptoms, not only diarrhea. Still, there can be nausea, vomiting, or abdominal pain. How to do? For patient with grade 1, no dose modification. For grade 2, usually we offer the patient the loperamide, and if the patient didn't improve within 1 day, you should really hold the medication till recovery. And if not, if it didn't resolve very fast, you should start with dose reduction. For grade 3 and grade 4, hold till the patient recover, and then start with dose reduction. Coming about QTC interval, we know that this is really, it is there, and it really can be a life-threatening situation. But what is the incidence? The incidence is about 8.4%. Any type of QT prolongation. Regarding the prolongation more than 500 milliseconds, it is only 1.3. Increasing with 60 milliseconds occur in about 5.6% of the population. And in the Mona Lisa 7, when they used tamoxifen together with the ribociclib, they found the percentage of the QT interval more than 60 milliseconds is about 16%. So it is really not advised at all to offer ribociclib together with tamoxifen because of the QT prolongation. And again, how can we manage if we found that grade 1 from 450 to 480, we can continue on the same dose. If it is above 481, we can wait till the patient recover, and we can just make a dose reduction. And in grade 3 and in grade 4, definitely we will just interrupt the treatment and make dose reduction. If it is grade 4 with one of the following trousseau points, polymorphic ventricular tachycardia, or an unexplained syncope, really we should hold the treatment permanently. How can we calculate the QTC interval? We have many formulas to calculate this, because really it will differ. The QT prolongation will differ according to the heart rate. This will just can make these numbers differ. So we have to use certain formula. And in this clinical trial study just published in Saudi Arabia,
Dr. Ahmed, 1 minute.
Okay, they found really the Fredericia formula is just the best to calculate this. So again, are you concerned that dose reduction can lead to inferior outcome? So I will just let me answer this question because of the time. Actually, just if we made dose reductions, this will not affect the outcome of the ribociclib. Back to our case, based on the persistent grade 3 neutropenia, we decrease the dose to 400, then to 200, and we can find that progressive drop in the CA15-3. And actually here in this clinical trial, the Mona Lisa 2 and 3 and 7, there was dose reduction in 40 to 60%, and it didn't affect the outcome of the patient, didn't affect the progression-free survival. As we can see here, and this is the analysis, we can see that there is no detrimental effect on the outcome of the patient who received the ribociclib with dose reduction. And finally here, this is the Emily trial. Just said, okay, why we don't start with a lower dose rather than going for 600 if at the end didn't affect the outcome of the patient. And in this clinical trial, it was supposed to show non-inferiority. However, it didn't meet the end point, and starting with 400 rather than 600, this is an inferior treatment regarding the response rate, although the progression-free survival didn't change because 40% of the patients that they had dose reduction. So the recommendation to start with 600 rather than 400. However, if there is toxicity, you can reduce the dose without fearing that the outcome will be less. Finally, there is the drug interaction. We really should take care of the drug-drug interaction because it really can affect the cytochrome system and can affect the metabolism of the CDK4/6 inhibitor. And so I advise everybody just to try to use one of the tools available, like cyclibtool.org or any of the programs available on the Android system. And here, this is monitoring the schedule. Just we should do the test in regularly every 2 weeks in the first 2 cycles, and then before every cycle till the first 6 cycles, and later on per demand. Back to our case, patient just went, as we can see, there is complete resolution of all the tumor, and despite we reduced the dose to only 200 milligram after only one month of treatment. However, now patient, when we did a recent CT PET scan, we found an eruption of new metastasis in the bone, and we did for the patient a comprehensive genomic profile. It showed mutation in the PIK3CA. And now the questions, which really I need an answer from you. What to do for this patient? We will just go for, as a patient who failed a CDK4/6 inhibitor, and they will go for our guidelines to check for the bulb and or to start with first line chemotherapy, or will still you try some sort of hormonal treatment before you consider the patient as hormone refractory, or would you like to go back to ribociclib again, but increasing the dose, just keeping in mind that the patient really showed much improvement in her general condition. She is now just coming regularly to the clinic, and she regained her power. We removed the feeding gastrostomy. So for this, just I need an answer from you. So what we'll do, re-escalate the dose again, or just to change the hormonal counterpart, or go for alpelisib based on the PIK3CA mutation, or you can go for third elcestrant, although no ECR mutation, or just to go directly to chemotherapy, or sacituzumab govitecan, or to take a new specimen, either liquid or solid, and based upon the new specimen you will decide. And this is the last slide, and I hope just to see your answer. Thank you.
Okay, thank you, Dr. Ahmed. Thank you for this case. And actually, we will move forward. But before we move, I just want to remind you of one thing. we have not a small booklet, it's actually a big booklet, but with few pages. And this is for you to use in the clinic. And if you flip through the pages, it has all what Dr. Ahmed showed in the slides in terms how to monitor the patient, plus how to do whenever you have any of the side effects, how to adjust the dose, when to stop, when to hold, when to reduce the dose, and so on. So everybody, you should take one of those booklets and use it in your clinic or keep it for the nurses in case they need any help with that. With that, I will move to our next presentation, which will be actually about more of a scientific part of and the keynote presentation for our workshop today. And it's my pleasure actually to introduce Professor Michael Grant, who is a professor of surgery and medicine at the Medical University of Vienna, Austria. And he is well known in the world of breast oncology, leading many actually publications in the world of breast cancer, whether for bone modifying agent or for advanced treatment in metastatic setting. And he will be presenting for us actually. The topic will be actually Beyond the Basics, Advanced Insight into CDK4/6 Inhibitor for our master class. I hope Professor Grant is with us. He's attending virtually because he has another presentation in Medina. So can we? You can start, Professor Grant.
So choosing based on overall results over the website. Excellent. Next slide. So the beauty is that's now second line. I think this was successful, but now very recently there is progression in one. I think the second line now recently moved some modern technology using biopsy for tissue biopsy, of course. And if we find a specific mutation that we can target, then as it is right here, in this case, we have to use it elastic, for instance, a couple of weeks instead of that. So we'll see what that brings based on the emerald trial. When you look at the progression of treatment hormones and breast patients, we have data from obviously, and from the two from the recent trials. And I think I have been doing a lot of screening of the present stage, it's a 7 homes per week in addressing this as you are aware of. And interestingly, and I have outlined here the post-operation results as you based on this, I have to say my friends and maybe my colleagues very prefer website, particularly for the patients. Let's start with the post-menopause setting. We can also again have the case she is a 64-year-old patient with retired school teacher. She between the 12th and 1 breast cancer, 15 was T2 and 1, and then she received really 3 years ago. Unfortunately, last December she came back with multiple metastases, and she's receiving letrozole, riboside together with Osma. Well, that question actually already resolved. That's based on the models results as we have seen 600 milligram riboside in comparison, and obviously the Paloma trials, as you know, together also we have second trials with clear differences in terms of the over survival outcomes. When you look at the slide. There we go. The post-menopause patients here, you see that the one is outside actually. And maybe we saw this in the monarchy trial. Now finally produced survival results, but unfortunately they were not the statistically significant, which I have to say is good luck for them, because it's still 1 year improvement over survival. But after all, this is why we use statistics that we can actually rely on the results we observe. setting, which I think is reasonably convincing. The overstrategies we already covered. So again, I apologize for the technical issues, but so a great discussion. Thank you very much for that.
Thank you, Dr. Sedman. I know you have another talk, a very short time, Medina. And for that reason, because of the rare time, we have a very short time for that. So we'll go actually to the next case presentation. And it's my pleasure to introduce Dr. Ahmed Antar. He's a medical oncologist at the head of oncology at the Moosa Hospital Group. And he will have also
Thank you again. Okay. So for the sake of time, I will try to finish in 10 minutes. So this is my case presentation. 62-year-old female patient, don't have hypertension, good performance status, referred from family medicine clinic and GI clinic for severe epigastric pain, nausea, vomiting, and significant weight loss. Okay, so after workup, they suspected malignancy, so they did the tumor markers, and CA53 was not very high. So they did for her CT chest abdomen pelvis, and it showed clearly breast mass, lesion, and liver and bone metastasis. So biopsy found that breast lesion showed clearly invasive lobular carcinoma, grade 2, HER2 low, ERPR positive, ECAD negative with signet ring cells present. And because the CT scan did not explain the severe epigastric pain, we did for her gastroscopy and colonoscopy because of the abdominal pain. And gastroscopy and colonoscopy both showed abnormal thickening, and biopsy from this abnormal thickening by the endoscopist showed by H&E stain cancer with GATA positive and ER positive and CK negative, so it's a metastasis. So it's an invasive lobular carcinoma with GI, liver metastasis and gastric metastasis and the colonoscopy and colon metastasis. So first question, what will you choose for this case? Metastatic breast cancers with severe symptoms, postmenopausal, chemotherapy, endocrine therapy with CDK inhibitor, or short course of chemotherapy followed by hormonal therapy. I will move. So the NCCN guidelines and the ESMO guidelines said we give only chemotherapy in case of visceral metastasis or visceral crisis, sorry, and in case of impending organ failure. So even if we have metastasis without impending organ failure and without the crisis, no need for chemotherapy. And this is the ESMO guidelines, chemotherapy ABC5, ESMO ISO guidelines. Chemotherapy is only indicated in case of visceral crisis. And even we have a study, right choice trial, but I did not put that slide because it's a standard of care. In this study, even if in severely symptomatic patient and even in the subgroup of visceral crisis, the patient showed better overall response rate with endocrine therapy and ribociclib, CDK inhibitor versus chemotherapy. But the standard of care is to give chemotherapy only in case of visceral crisis and impending organ failure. So the second question, if we will choose a CDK inhibitor, which one? Ribociclib, palbociclib, or abemaciclib? So this is the trials of CDK4/6 inhibitors. All the primary endpoint was progression-free survival, and almost all they have the same progression-free survival hazard ratio. And these are the trials for most postmenopausal patients, because our patient is postmenopausal. It's not working. So Paloma 2, palbociclib, Mona Lisa, ribociclib with AI, and Monarch E, abemaciclib with AI, all showed the same progression-free survival hazard ratio. So this is the Paloma 2, significant progression-free survival benefit in palbo-letrozole arm, and this is the overall survival in Paloma trial. No overall survival benefit in the Paloma. So this is the first endpoint was progressive survival, but overall survival no benefit. However, in the real world data for the palbociclib, real world data, overall survival, there is benefit, but this is not randomized trial. And for the Mona Lisa trial, also progression-free survival, significant benefit in favor of ribociclib, and even overall survival benefit in ribociclib arm with significant p-value. And for abemaciclib, we have progression-free survival benefit, and for overall survival benefit, we have benefit, however, it's not statistically significant. So why there is a difference between the results? There is no head-to-head comparison. Although we have a clinical trial now is running in Harmonia trial in HER2-enriched patients that compares palbociclib versus ribociclib. This is the only one head-to-head trial, but there's no results yet. It's recruiting. So difference in CDK inhibitors, the dose is different. For palbociclib, 125, 3 weeks, 1 week off. For ribo, 600, 3 weeks, 1 week off in metastatic setting. Abemaciclib, continuous. CNS penetration only in abemaciclib we have a data. Cytopenia, all they cause cytopenia, but less in abemaciclib. Fatigue, all they can cause fatigue. And diarrhea, mostly in abemaciclib, but it's easily manageable, and only the first few weeks. And QT prolongation mainly in ribociclib. So this is the FDA approval as first line and second line for all these CDK. And this is the NCCN guidelines. All are indicated as first line, but they put ribociclib category 1 because we have overall survival data. And for ESMO guidelines, all are indicated as first line. Now what about the dose? If we choose ribociclib, like in our patient, we choose ribociclib, what about the dose? So the standard of care in metastatic setting is to use 600 milligram. Although we know from Mona Lisa 2 trials that dose modification, 1 or 2 dose modification to 400, even to 200, do not affect survival. And this is one of the rationale of Natalie trial in the adjuvant setting that choose 400 milligram for ribociclib. And you know in Natalie trial, the toxicity profile in 400 milligram is not working. In 400 milligram compared to 600 milligram, significant decrease in neutropenia and significant decrease in QT prolongation. However, the liver toxicity was the same. So it's not a dose effect, liver toxicity. So back to our patient, we use ribociclib, 600 milligram plus AI letrozole. After only 1 month, we were obliged to decrease the dose because of toxicity to 400 milligram because of neutropenia due to myelotoxicity. And then the patient has excellent continuous response till now. It's almost 3 years on ribociclib, 400 milligram, in addition to letrozole and denosumab. So, and resolution of GI symptoms after almost 2 months, complete resolution and improvement after 2 weeks. So this is a CA15-3 decreasing, but never reached normal. And this is a CT scan. It's very obvious. Liver lesions almost disappear. Only we have a scar in last CT scan in December 2023. So last question for elderly patients. Can we use, which one we can use in elderly patient? So we have data in all CDK inhibitor in elderly patient. So in ribociclib, we have data that regardless of the age, less than 65, 65 to 75, and more than 75, we have effect, and we have progression-free survival over survival effect, regardless of the age. So take-home message based on this case. So chemotherapy is only indicated in cases of visceral crisis and impending organ failure. Any one of CDK inhibitor we can choose as first line, but we have overall survival data only on ribociclib. We have to choose based on the toxicity profile. All have progression-free survival, all approved in ESMO and NCCN guidelines, but ribociclib is category 1 in NCCN guidelines because of the overall survival benefit. And we can, for all, reduce the dose, and in all CDK inhibitor, reducing the dose do not affect the progression-free survival or do not affect the efficacy. And thank you.
Thank you, Dr. Ahmed, for this case presentation. We have few panelists with us in the audience, and we have the speakers here up in the podium. So if anyone has a question for them, we can start. But let me just kick it off with one question. So regarding elderly, from your experience, for both speakers, from your experience, did you notice any significant toxicity when you use any of the CDK4/6 inhibitors?
يعني mainly the hematological toxicity with the CDK4/6 inhibitors and diarrhea with abemaciclib. This is really the most common side effect we see with our patient. Sometimes transaminitis, just we see it in some of the patient, but most of it really manageable. And as you can see, in most of the CDK4/6 inhibitor, if even you reduce the dose, still you are safe, still you can achieve the same outcome.
Dr. Anter, did you have to change the dose or switch from one of the medication to another?
So for toxicity, as mentioned by Dr. Ahmed, mainly neutropenia in ribociclib and palbociclib, and I used to decrease the dose, and it's manageable after reducing the dose. And for abemaciclib, mainly diarrhea, but also it's easily manageable. Rarely we discontinue the medication because of diarrhea.
Anything specific about older population, or you think they do the same just like younger people?
For toxicity.
In terms of toxicity and switching?
For patients, for example, with extensive liver metastasis, and we are afraid about the liver toxicity, maybe we can choose abemaciclib or palbociclib rather than ribociclib. For patients with cardiac problem, maybe we can avoid ribociclib. For patients with GI problem, we can avoid abemaciclib.
It's mainly due to the pattern of the disease. For example, my patient has severe bone
think we tolerate, especially in our local population, which they start with lower white cell count to begin with.
Yani, I think everybody agrees that grade 1 and grade 2 will just keep the same dose. But nowadays, some of us are more brave, even for grade 3, up to 800, 700. Sometimes we just keep the patient on the same dose. We don't make dose reduction with this, especially if the patient general health is good and there is no clinical symptoms whatsoever. So I think we are more tolerable now, and we are more brave, and we have more experience with the CDK4/6 inhibitors right now.
I will take this chance to just invite the panelists, Dr. Talib, Dr. Assam, Dr. Al Khair, and Dr. Saud to the podium, please. So for the speakers, Dr. Rahman, Dr. Rahman, Keith Abdurrahman. So for the speakers, mainly we were focusing on their cases and their presentation. But now I just want from the panelists to give me just their thought of the difference between the outcomes that we measure now in earlier lines of metastatic breast cancer. Dr. Abdurrahman, just give me a thought. Yeah, give me a thought on the outcomes that they choose for all the study. Was the primary disease-free survival versus overall survival? What's your thought on that?
I think overall survival should be the main point if you choose the first-line treatment. Because first-line treatment, if you have 3 options, for example, which one will be, and all of them doing great in terms of side effects, in terms of progression-free survival, but which one is stand out? Of course, the one that extends the life of the patient. So this is why overall survival, in particular in first-line treatment, should be the most important endpoint.
Dr. Talib, do you think the population in all the studies for the first-line setting, do you think the population are the same for all the drugs, or do you think there are some differences that led that the overall survival was different?
No, there is a difference still, and overall survival sometimes it's different from population to another population, like Asian different from the Caucasian or ethnic. So it depends on the ethnicity of the population. So it can play a major role, but still overall survival is the primary. It is a good and also, it's a primary endpoint. But still PFS is one of the important goal of the study.
Dr. Assam, from an authority perspective, what do you think should be done? Should we focus on overall survival when we just bring any drugs to the formulary, or we should include all the drugs and have the chance for the physician to choose based on side effects?
I said it so many times. The 3 options should be there. You have to bear in mind, although we have survival advantage, that is a secondary point, okay? And this is very important when you make your choices. You have to pay attention to BFS2 at the same time, which is in favor of other options. And you have to put in consideration the toxicity profile, okay? So choosing your treatment to your patient will be based on these 3 factors. Sometimes, which a little bit I disagree with Ahmed when he mentioned about the dose reduction, that we don't do it. We do it. Confidently we do it because we have evidence to show that even if you reduce the dose, you maintain the same efficacy. So we should not promote that to be very aggressive with the full dose in patient with bone marrow suppression, which though benign, okay, but sometimes some of the elderly patients, they don't recover from it, and then you put them at stake. So reducing the dose is there, which maintain the efficacy of almost the 3 medications, and we should not promote against this. Thank you.
Dr. Al Khair, do you believe in switching from one CDK4/6 to another CDK4/6 at the same patient?
It depends on the reason why I'm switching. If it is because of side effect, definitely. I do it usually in the clinic. And this is the beauty of having the 3 medications. But I know that there is a study and it showed that the efficacy of ribo after, but it depends on the extent also of disease, the progression where. Sometimes I have to break it with chemo, for example, and then I rethink to re-challenge, but not on a routine base.
Okay. Dr. Saud, my question to you is, do you believe in a second, increasing the dose of the CDK4/6 or use it after a failure of one of the CDK4/6?
Can you repeat
using CDK4/6 inhibitors again as a like after failure of CDK4/6 inhibitor?
It's dependent on what you start with first. Like if you start with palbociclib and the patient fail or had side effects, you can use the ribociclib based on the studies. Yeah, that's an option you can, because like the goal here to give the patient as much as we can with the medication itself. So yeah, that can be used, but again, the beauty of the 3 medications, as everyone said, it's you can tailor it based on your patients. And to go back about the neutropenia, I have a couple of patients that the ANC below 1,000, and I continue with the same dose. Again, because most of our population here is like have benign neutropenia. So if they don't have fevers or infections, I just continue with the same dose to maximize the benefit.
So, but mainly you use it for toxicity, you switch. But do you think if one of those CDK4/6 failed totally and the patient progressed, do you think giving them another CDK4/6?
It's depend on the timing, like how long the patient was on the medications, okay, and what the combination. What was it? It was the AI, or you're gonna like, or so you're gonna switch it with another one with fulvestrant or not? So that has to be also like to be taken in considerations. I think yes, and again, it's depend on the patient himself.
All right. Any question from the audience or comment?
And I have a question for the panelists. How do you interpret the overall survival data in real-world data for palbociclib?
Let's start with Rahman. That's yeah. Some questions are loaded politically.
So definitely CDK4/6 inhibitor is a class effect. There is a class effect of benefit. You noticed the chemical structure of the compound is different, and this is why there is a different side effect. And maybe there is a different efficacy. But when you go into real world, you're out of the control environment of the study. So we believe more in science. We believe in randomized controlled trial. But is the data from real world data, is it totally out of the line? No, of course. So, for example, if you have a patient that come with a stage 4 disease and you don't have any option in front of you, if you have the 3 options, it's obviously what to choose based on the data. But for example, you are in a hospital and you have only one option. So you have real world data and you go with that one option. So this is how I would include all the medications.
Dr. Talib, in the study, the second line treatment for all those 3 studies, only 20 to 30 patients receive CDK4/6 in the standard arm after failure of the hormonal therapy. What are your thoughts about that in terms of effect on survival? Do you think it affects that survival was?
Of course, it affects the survival. As we know that CDK4/6 inhibitors is very important to prolong the PFS, and also there is a data, especially other CDK4/6 inhibitors that increase the overall survival is positive, like ribo. So, yes. And just a comment for real-world data for Dr. Anta question. Real-world data is just it's a confirmatory things for the trial itself. So, and it is reflecting the practice of the physician. And real-world data actually show that it is a positive, and overall PFS is more in terms of like palbociclib more than the trial itself.
Dr. Assam, if you want to design another study for CDK4/6, what will be your arms?
Head to head.
Head to head. Okay. Dr. Omar,
We want to design a trial?
Yeah. Or we will not do it?
Actually, they included everything in all the trial, but for the last 2 years we are discussing this too much. I don't think about, we expose the premenopausal. There is a trial for it. There is for postmenopausal. There is a real world. Switching, I don't think, there are reasons for it. And what I do, I believe that I have to have the 3 medications because of, definitely they are a class effect, but there are some changes and there are some differences between them. And this is apparent with the creatinine elevation with abemaciclib, with hepatotoxicity in both abema and ribo, neutropenia more with balbo. So it's nice to have the 3 medication so you can choose among them. But if it is important to choose 2, I will do, for example, abema and ribo.
One last thing for Dr. Saroud. Now we are in the era of using CDK4/6 in the curative population or for in the initial adjuvant setting. In case of failure, when do you think starting a CDK4/6 for metastasis is reasonable, and when do you think we should switch to a different line of therapy after failure of the adjuvant CDK4/6? Is there a time that you look for in terms of failure?
First, let's talk about the population that you're going to give the adjuvant for. Again, there is a specific definition like in the CC guidelines for these patients, and it's also like a consideration. So it's not like I think, and that's a question I will ask back to the panelists who will consider it to his patient and who's now will keep it for later on. To answer your questions, I think I will maybe recycle it after if the patient relapse after the 2 years the patient on the adjuvant treatment. But there is a trial. I'm not sure if there is something going on now, not yet. But that could be one of the trial has to be done to see how can we recycle this medication again after using it in the adjuvant setting. So I'm asking the panelists, anyone has any experience using the adjuvant and the patient relapse? Because this is all of it's like a new data, so.
Yeah, I don't think anyone has. I mean, it's too early to say. But do you have anything? The microphone.
Just to look for there's a medication resistance, so you can. No, I don't think there's a trial or something data about this, but. In terms of relapse, I think you may eligible to do some test looking for a resistance mechanism like ESR1 and looking for this resistance. And if there's a resistance...
Yeah, I think I will apply the same rule as we applied if a patient is hormone refractory or hormone sensitive like we are doing with the aromatase inhibitor. So if the patient is still entitled like our previous rule as hormone sensitive, I can use this medication. And if it is hormone refractory, I will just think about something else. This is just, if I would make a clinical trial, I'll make it on such way.
Do you have any comment? I think we are in a data-free zone here, okay? Adjuvant is just a new thing. We don't have any evidence to tell us what to do after the adjuvant, though we don't have any data on recurrence after adjuvant yet. And bearing in mind that you may start 12 to 16 months after the end of or the diagnosis. So it's a data-free zone. When you are in a data-free zone, you can do whatever you want.
Yeah, so it's a data-free zone, but in metastatics, I think patients should get CDK4/6 inhibitor again, because, no, I understand, but we have maintained trial. This is in the metastatic setting, and we can go CDK4 beyond CDK4. So, and it showed some efficacy. So hopefully that can be also applied to adjuvant and metastatic. There is no time, actually. They start beyond it. But what happens, they switch the CDK4/6, and also they switch most likely the backbone of the endocrine therapy.
Okay. All right. I think with that, thank you all. And thank the panelists, thank the speaker, thank Novartis for sponsoring this master class. And we will move with our program, and hopefully we'll finish before the prayer time. It's my pleasure to introduce actually the next moderator, Dr. Abdul Talib Al-Adnan, and also he will
Assalamu alaikum. Good morning, everyone. First of all, I would like to congratulate Al Moosa Specialist Hospital for the fantastic and elegant organization of this extraordinary conference. And I wish you guys all the best and luck in the future. Now we move to our next session on the agenda, and this will be a satellite symposium sponsored by our partners at Gilead. So over the next 20 minutes or so, we will enjoy a talk and discussion about the role of ADCs, antibody drug conjugates, in the management of metastatic hormone receptor positive, HER2 negative breast cancer. As you know, this is a rapidly evolving topic, practice changing, with a significant impact on the guideline and treatment algorithm. Our speaker is Dr. Ahmed Louabari, a hematology and oncology consultant at Al Moosa Specialist Hospital and assistant professor at University of Arkansas, the United States. Please, Dr. Ahmed.
Thank you very much, Dr. Abdul Muttalib. Also, the Gilead Group, Jordan Mohammed, thank you for the opportunity. Does this thing work? I'm going to use the mic, thank you. All right, so I will discuss the ADCs in ER positives specifically. I will be talking about sacituzumab govitecan mainly, and then we'll go over some of the ADCs quickly. So this is the disclosure, and this is the outline of the talk. We'll have a background, then we'll talk about the TROPICS trial, and then other ADCs, and then we'll touch on the prospective, future prospective, and finally we'll end with a proposed guideline. All right, so TROP2 is a receptor. It's a transmembrane receptor that's mainly found in a newly generated tumor cells. So in other words, a fresh tumor tissue will have a higher expression of TROP2. And it's mainly found in triple negative and in non-small cell lung cancer, among others. So you expect that in the future, the govitecan will be part of non-small cell lung cancer. In fact, I know that there are multiple phase 3 trials in combination with immune therapy and first line in non-small cell lung cancer. The design of all of the antibody drug conjugates is a monoclonal antibody with a binding site and a payload with a linker. Now, there are differences on how you design this monoclonal antibody. In other words, IgG1 and IgG3, they have, besides being a delivery molecule, they do have the ability to stimulate the immune response by ADCC and by activating the complements. One of the mechanism of action proposed for trastuzumab, initially we thought that this is a signal transduction molecule, that we switch off the HER2 receptors by giving trastuzumab. Turns out that the IgG activation of the immune response is even more important than that, okay? And that came down the road. So IgG1, IgG3 they have the ability to activate the immune response. IgG2, IgG4, they are less able to activate the immune response, but they're at the same time a good delivery mechanism without, quote unquote, an immune response. Now, the whole idea of antibody drug conjugate is that you deliver a the payload all the way to the cell without leaking the payload in the system. Most of the new ADCs have the ability to do that. The issue is you need to have the linker to be sensitive at the tissue level to release its payload, and for the payload to permeate to the neighboring cell to kill it. So for instance, TDM1 is so stable, it does not release the payload except in the cell that it's destroyed. So that's why it's only effective in HER2 positive, and it does not have a bystander effect. And our friends in hematology have ADCs for a long time ago. I don't know if gemtuzumab still used in AML. Yeah, I know that it was withdrawn from the market briefly in the United States, and Cantargian wanted to bring it back for certain patients. But definitely we have the ADC, it's not something new, but we are refining the production in the pharma and refining the use of these medications. Now, sacituzumab govitecan is an anti-trophoblastic 2 ADC. So basically it has a TROP2 target. We discussed that TROP2 target is abundant in breast cancer and non-small cell cancer, and it's more abundant I would expect more abundant on the metastatic than on the original tissue. As we said, it's a newly generated cell. And it has the linked or the payload is SN38, which is topoisomerase 1 inhibitor. It's similar to the same family as irinotecan. It's much more effective than irinotecan. I'm just going to go quickly over the ASCENT trial. So the ASCENT trial that really cemented sacituzumab govitecan role in breast cancer is for triple negative, metastatic triple negative, heavily pretreated. None before sacituzumab, none of the agents showed any survival benefit in a setting like this. They were randomized to receive sacituzumab govitecan versus physician choice. The trial was halted, was stopped prematurely because it was found unethical to continue the trial because of these things, more than doubling, tripling of progression-free survival and overall survival, and it became really standard of care in patients who have had the same setting, triple negative, second line or third line and beyond. Now, because of the effect in triple negative, the investigators thought that they can probably test it in ER positive, and that's exactly what happened. So these patients have been exposed to, this is ER positive metastatic breast cancer, have had CDK4/6 inhibitor like the standard of care, 2 lines, but not more than 4 lines of chemotherapy in the metastatic setting. And they consider, by the way, neoadjuvant and adjuvant as 1 line of treatment. So if the patient has neoadjuvant, adjuvant, you can consider that as 1 line. The randomization is, look at the, obviously, sacituzumab govitecan, which is given day 1 and day 8, but look at the chemotherapy. These are the chemotherapy that we use. These are the chemotherapy, this is actually represent the practice. So Xeloda, eribulin, navalbine, Gemzar, these are the medications that you use in the clinic. The primary endpoint here is progression-free survival, and secondary endpoint is overall survival. Now, couple of points. Very heavily liver metastasis in around close to 90% or 85%. Look at that. There are 60% of patients are hormone resistant, and around the median prior chemotherapy is 3. Okay, and this is important. 100%, close to 100% received CDK4/6 inhibitors. This is the primary endpoint. There is improvement, a hazard ratio of 0.66. Now, if you look specifically at the median progression-free survival, it's not that impressive. 5.5 months versus 4 months. But over time, I'd like you to look at the 12 months progression-free survival. 7% versus 21%. So over time, really, those who respond to the treatment, they stay on the treatment for a very long time. And remember that this is compared to what we use in the clinic. Now, again, those who cross the hazard ratio line, if you note, are the hormone sensitive. More than 12 months on CDK4/6 inhibitors, and those with bone metastasis only, so not the sicker patients. Again, overall survival is positive. It added around 2 months into the overall survival. And the clinical benefit rate, as well as overall response rate is much higher. Now, this is the updated that was presented in ASCO of last year, and it showed that the 18 months, it's a 1.6 years, 4 versus 15 months. Again, that's really good news for sacituzumab. Nothing new about the subgroup analysis. The overall survival at a 24 months updates, again, there is an improvement in overall survival in favor of sacituzumab. Now, it doesn't matter really whether they have high or low expression of TROP2, but the prognosis is better, or the response is better with high expression of TROP2. We know that HER2 low are better than HER2 negative. This is regardless, this is the prognosis. It's an independent prognostic factor. HER2 low is better than HER2 negative. And again, you see that in HER2 low, also the response to sacituzumab is better than those with HER2 negative, but still they have they do respond to both of these agents. Now, the discontinuation rate is similar between the physician choice and the sacituzumab, but the dose reduction is around 66% dose delays and reduction with sacituzumab. Now, if I would want to talk about side effects of sacituzumab, it would be neutropenia, diarrhea, fatigue, and obviously patients care about hair loss, and this is a medication that causes hair loss. But the quality of life is maintained. In fact, it's better if you look at the fatigue scale, and as a global health scale, the half-life, the sacituzumab improves that compared to physician choice. So the bottom line here, 35% reduction in progression, 21% reduction in death, and it is one of the options. I'll tell you that as chemotherapy, this is the only chemotherapy in ER positive metastatic breast cancer that showed improvement in overall survival, period. All right, trastuzumab deruxtecan will be discussed in next lecture, so it's going to be a couple of words. We know that in HER2 positive, compared to the standard of care at the time, obviously it improves to the overall survival, so it is the standard of care. And in ER positive HER2 low or ER negative HER2 low, it was compared to physician choice, similar in similar setting to the govitecan, and again, it improves actually overall survival in hormone positive. Couple of words on datopotamab deruxtecan. So this is a hybrid between the two. So this is anti-TROP2 with deruxtecan, okay? And if I'm not mistaken, it's Gilead also. I don't know. Is it Gilead molecule? Huh? No? No, okay. All right. So someone want to steal the from Gilead and from AstraZeneca. The bottom line is that this is an anti-TROP2 with deruxtecan in triple negative. It really showed a reasonable response, and it's now in phase 3 trials. I know that one of the side effects of this treatment is ocular toxicity, so it's not really favorable, but maybe they can identify the mechanism behind it and ameliorate it. And where do we go from here? So we know that in triple negative we improved the overall survival for those patients, but I think the combination with immune therapy, because we know it is in early phases in lung, it was effective, and we believe that this is going to be the case in breast cancer, but this is ongoing. This is the trial, and again, same story in early breast cancer, sacituzumab will be also studied in early breast cancer with this trial. So a couple of words about managing side effects. The bottom line, with sacituzumab, these patients are heavily pretreated. Just use G-CSF for neutropenia prophylactically, and they should be fine. For diarrhea, however, if you have an acute diarrhea, on treatment diarrhea, atropine is the treatment of choice, and because remember, this is just irinotecan, right? And then if there is a late diarrhea, use loperamide. So just keep that in mind. And finally, how to sequence. This is the biggest question, is how to sequence ADCs. This is a Mass General poster at ASCO, I think 2023. It doesn't matter what you use first. The subsequent ADC just have a lower response rate. So if you use sacituzumab in the beginning, or the opposite. So we need to be very careful on choosing what ADC we use in the first line. So this is the guideline that I have taken from one of the websites and played with it a little bit. So this is where they fall in the fourth line, technically, the ADCs. Okay, I don't think that ADCs should be in third line, honestly. The question is, do we need chemotherapy before we use ADC? Because the approval, for instance, for govitecan is after 2 systemic therapy. So doesn't mean that we can use them before ADCs. The trial used chemotherapy before ADC, so I would definitely consider that. I probably use here maybe Soloda or oral navalbine or something, or maybe even taxane before I go to these agents, especially that they are pretty expensive in the non-private setting. And here is the guidelines that I think is also reasonable for what ADC to choose when. And this is for HER2 low, I will use TDXD. For HER2 zero, I will use govitecan, sacituzumab govitecan. I think, I know that we went back and forth on the HER2 low and the fact that it's a small subgroup, 60 patients in Destiny DBO4, but I think it's very reasonable to choose TDXD for HER2 low. Thank you very much.
Thank you very much, Dr. Ahmed. Very inspiring as usual. So I will take a few questions, and I will start with a question of mine. So should we test for TROP2 level of expression just to predict the level of response to treatment? Is it something?
Well, we know that there is a benefit in progression-free survival and overall survival, whether it's low or high. So it's not going to change our management. It may be from academic standpoint that you test it to kind of, as you said, predict a higher response versus not so high response. But I don't think from practical standpoint that we should.
Yeah, thank you very much, Ahmed. So based on the data you presented, and as you mentioned, this is in heavily pretreated patients, and the quality of life is matters here, giving the toxicity profile of all of these medications. Is it wise to choose based on quality of life for these patients, despite, regardless of PFS or overall survival data?
Well, I say this is a very good question. I think that these metastatic patients, especially after many lines of treatment, they really become so sensitive to side effects, right? Especially the fatigue, for instance. Nausea and vomiting and diarrhea can be controlled. Problem with fatigue that we don't have a good, effective method to deal with it. But at the same time, if you control the disease, most often than not, the patient feels better. So using an effective treatment, at the end of the day, it seems like from practical standpoint, patients' quality of life improve. To be honest with you, even if it's just the fact that the disease is controlled, and I'm happy that the disease is controlled, and I will be more active, I will بنظر للحياة بنظرة وردية, as opposed to giving the patient less effective medicine, the disease is not under control, it's back and forth. And with ADCs, remember that it's your first medication is more important than the second medication, so you have to choose wisely, I guess.
Any other question? So one more question.
Okay.
Where do we see sacituzumab in the future? Is it going to come earlier in the treatment algorithm, earlier line, I mean?
It may. It's really in triple negative, the options that we have are not the greatest. Because the combination of, in the Keynote 522, is not the easiest combinations. Immune therapy, carboplatin and Taxol, and AC. So if they beat that, okay, if they improved PCR in a fashion similar to the combination, I think it will be in the earlier setting. But I think it's very early now to speak about it.
Thank you, Dr. Ahmed. So I think now we can conclude this session and we move to the next session, which will be moderated by you yourself.
Thank you very much. يعطيك العافية. So as I promised during my talk that I didn't speak about the TDXD because in the coming 15 minutes ايش رايك حطيتك في بوكس كذا. Dr. Ahmed Antar will discuss the paradigm shift in management of HER2-low metastatic breast cancer. طبعا Ahmed, let me just say one word about Ahmed. I was pleasantly surprised, honestly, to work with Ahmed because Ahmed is really very knowledgeable, and I'm just saying this honestly, and he's very easy to work with. And in fact, he made my transition from the government to the private very smooth. So thank you very much, and go ahead.
Thank you, Dr. Wabari. So the evolving role of ADCs in HER2-low metastatic breast cancer. So my outline, I will talk about HER2-negative disease background, evolving of HER2-low disease, pharmacological attributes to TDXD, destiny for breast for trial, selection of HER2-low, and conclusion guidelines. So this is the traditional treatment algorithm based on the HER2 status. So we used to do immunohistochemistry if immunostain is HER2 is 0, so it's negative, and if +1 or +2 is ish negative, it's negative, and if 2+ and more, 3+, so it's positive. So based on this algorithm, 15 to 20% of cases will be HER2 positive, and 80 to 85% of cases will be HER2 negative. So the HER2 negative disease based on this classification divided into hormone receptor positive with median survival 5 years, mainly hormonal therapy treatment, and triple negative disease 15%, and the treatment mainly chemotherapy with very aggressive disease. So this is a score again, HER2 score 0, it's negative. HER2 score +1 or +2 with H negative is HER2 negative. So now the question, could they benefit, this these two types with HER2 +1 or +2 H negative, could they benefit from HER2 blockade? Because you know all breast cancer, they have expression of HER2. So this is historical data. No benefit of adjuvant trastuzumab for HER2 low patients in the NSABP trial. Also for pertuzumab, there is some data and showed no benefit, clinical benefit of pertuzumab in HER2 low metastatic breast cancer. And also, one come to first antibody drug conjugate, the TDM1, there is some data, retrospective data, that showed no overall response rate. Then came the TDXT. So TDXT have a lot of characteristics, mainly three. The first one is the antibody chemo ratio, or drug to antibody ratio. It's 8:1. The second one is easily cleavable. We have the cleavable linker, and the payload with strong chemotherapy, the topoisomerase 1, like irinotecan. So by these characteristics, TDXT internalize the tumor cell, and then it's cleaved in the cell, the topoisomerase 1, and then the chemotherapy is permeable. It can cross the cell and go to other cells, even if the other cells are HER2 negative. So this is a bystander effect. This is the difference between TDXT and TDM1. Chemotherapy payload is different. Drug to antibody ratio 8:1 versus 3.5:1. And the tumor selective cleavable linker, yes for TDXT, no for TDM1, and bystander effect is obvious in TDXT. So this is a phase 1 trial published initially in ASCO guidelines for TDXT in HER2 low that showed overall response rate. Both on these studies, we'll talk about the phase 3 trial. But before, this is a new classification for HER2 immunostain. So based on this classification, if we have a 0 HER2, it's negative. If we have +1 or +2 H negative, so it's HER2 low. And +3, it's HER2 positive. Based on this classification, HER2 positive is only 15%, and HER2 low 45 to 55%, and HER2 negative 30 to 40%. And for hormone receptor positive, we have 60% are HER2 positive, HER2 low, and for triple negative, we have 40% HER2 low. And there is a trend, or there is HER2 expression increase with ER expression. So being 40% in triple negative, 46 in HER2 in ER low, and 62% in ER high. So this is a Destiny trial 4, randomized phase 3 trial. All patients with HER2 low, means immunostain +1 or +2 H negative. Prior chemotherapy, at least one line of chemotherapy, and hormone receptor positive. So the randomized 2:1, TDXT, the regular dose, versus chemotherapy physician choice. The primary endpoint was progression-free survival, and secondary endpoint was progression-free survival for all patients, and the hormone receptor positive, and overall survival. This is the statistical analysis, patient disposition. So in this trial, there is 10% of patients with triple negative, hormone receptor negative, triple negative, and HER2 low, 10%. 42 patients in TDXT and 42 in chemotherapy arm. And 90% of patients were hormone receptor positive. The patients, they have liver metastasis, lung metastasis, asymptomatic brain metastasis. Okay, the line of treatment, at least one of chemotherapy. And most of the patients receive CDK4/6 inhibitor, the hormone receptor positive patients. And this is the data. Progression-free survival obviously favor TDXD in all patients, and in hormone receptor positive patients, there's decrease in progression, 63% and 64%. All subgroup analysis favor progression-free survival in hormone receptor positive in favor of TDXD, and also in all patients favor TDXD. And this is the overall survival. There is overall survival benefit, significant p-value with hazard ratio of 0.69 in all patients and in hormone receptor positive patients. So there is decrease in deaths 31% and in TDXD arm. And this is the subgroup analysis also. So efficacy of HER2 negative, this is exploratory analysis. As I mentioned, only 10% of cases were hormone receptor negative, but in the exploratory analysis, it showed clearly that there is benefit in overall survival and progression-free survival in TDXD arm and overall survival. And this is a response rate, 52.6% in TDXD versus 16% only on hormone receptor positive, and 50% in hormone receptor negative versus 16.7. So it's obvious. And also progression-free survival 2 that reflects the cumulative effect of using TDXD as first line, also in favor of TDXD, 15.5 versus 10.5 months. And this is the waterfall, also the target lesions favor of TDXD. And the safety profile, it's different, the safety profile, the toxicity is different between TDXD and the chemotherapy. So the most common adverse event that lead to discontinuation of patients receiving TDXD were interstitial lung disease and pneumonitis versus peripheral sensory neuropathy in the chemotherapy arm. Also, here we noted it's chemotherapy, anti-drug conjugate TDXD, it's like chemotherapy. It causes alopecia, it causes more nausea than the arm of chemotherapy. For neutropenia, maybe chemotherapy showed more neutropenia. And diarrhea, almost the same. So it's a chemotherapy. So what is concerned is interstitial lung disease. That's why we do CT scan, higher resolution CT scan every 6 weeks. Is that a recommendation? To detect grade 1, if we have a grade 1 interstitial lung disease, means asymptomatic patient only by CT scan, we can stop the medication for a while and treat by steroid. So the grade, any grade of interstitial lung disease is 45. However, mortality or grade 5 only 4. Compared to chemotherapy, no interstitial lung disease. Heart failure, it's a trastuzumab-based medication, so heart failure and ejection fraction decrease there is, but no grade 4 or grade 5. So the results, this is the results of the outcome of a longer follow-up of this 4, continue to support the use of TDXD as a new standard of care after first-line chemotherapy in patients with HER2 low metastatic breast cancer. And this is also exploratory analysis published and presented in ASCO in patients with asymptomatic brain metastasis, 24 patients in TDXD and 11 patients in chemotherapy. And it showed better overall response rate and the clinical benefit rate and the disease response rate, disease confirmed, DCR rate, favor of TDXD. So it works in patients with brain metastasis, asymptomatic brain metastasis based on this exploratory analysis. And now, how to select the HER2 low patients? It doesn't matter whether the primary or metastatic disease, whether the archival tissue or newly diagnosed tissue, so any tissue can work for HER2. And what is important for the pathologist is to put in the report if it's HER2 low, if it's 0, +1, +2, so it's very important. And this is the ESMO guidelines. So in hormone receptor positive, the first line, if there is no impending organ failure, is ET with the CDK4/6 inhibitor. After a progression, we check PALB and the BRCA. If negative and no imminent organ failure, second-line everolimus exemestane or PIX3 mutated patients alperzilib with fulvestrant, if ESR positive elcastrant, and if BRCA positive olaparib. And in case of progression, if HER2 0 SG and if HER2 low TDXD. And thank you.
Thank you very much, Ahmed. Thanks for the discussion and sticking to the time. Okay. So questions? Anybody has questions? Let me ask you, Ahmed. During my presentation, I claim that for HER2 low ER positive, the drug of choice is TDXD. Now, Dr. Hashim question was loaded. So he said, for those with metastatic breast cancer, wouldn't you choose the drug that's more tolerated? So what do you think? So for ER positive, HER2 low, and for ER negative, HER2 low, what's the drug of choice?
So for ER positive, HER2 low, I would choose TDXD because it's well studied in this trial in earlier chemotherapy setting, after one line of chemotherapy. For SG, the data is after 2 lines of chemotherapy. So as you mentioned, we cannot wait 2 lines of chemotherapy. So for hormone receptor positive, first line chemotherapy, after that I will choose TDXD. But for triple negative or hormone receptor negative, I think we have to choose SG.
So my point is the benefit in DB04, although it's exploratory analysis on 60 patients.
There is benefit.
That benefit is staggering, almost 10 months improvement in overall survival. So to be honest with you, I will, for HER2, any HER2 low, I will choose TDXD. For triple negative, obviously, or HER2 negative, whether it's ER positive HER2 negative or it's ER negative HER2 negative, then the SG is the drug of choice. And the reason why I say this, because this discussion has been back and forth whether the data on TDXD is from exploratory analysis, small number of patients, but I think that the degree of benefit supersedes, that's what I think.
The ESMO consensus, more than 90% I think of specialists in ESMO consensus, they would prefer SG in hormone receptor negative. However, as you mentioned, if you use SG, the second one is TDXD, and if you use TDXD, the second one is SG. And maybe we will have a better response to answer to this question when we get the result of Ascent 7 trial. I think it's in hormone receptor positive and earlier lines chemotherapy.
Is it 7 or 6? DOB 6, I think. Oh, 7, Ascent 7, yeah. Okay.
HER2 positive.
Yeah. You want that?
Earlier lines of chemotherapy. And also Destiny 6.
Yeah, I just have another question regarding HER2-low. We know that HER2-low is not stable expressions and is dynamic from primary and progression. So how frequent we have to test for HER2-low? Is it in each progressions, or we just retest the previous biopsy to check it? And how to choose from where to choose to take the biopsy?
Good question.
Based on the Destiny 4 trial, it doesn't matter whether to use a biopsy from metastasis or from primary site. So I think in our practice, we don't repeat it unless if it was negative and we have a progression after a few years, or maybe we have to test it again from metastatic site. What do you think?
So for HER2 low, there are already published data on repeated biopsy. If you take 5 biopsy, the chances of finding HER2 low is 80%. Okay, so the bottom line, if you take a biopsy and it's negative, go ahead, do another and do another, maybe another side, because of tumor heterogeneity. I spoke with Dr. Viali from Milano about this specific, the dynamic of HER2-low and whatnot. And he said that, the TDXD is so effective, I just want to find any reason to give it. So that's why finding biopsy, clearly if you have 5 biopsies and 4 negative, that means the tumor is in what? 80% of the heterogeneity is negative for HER2-low. But despite that, for the 5th biopsy is positive, and you end up having a response to TDXD. Okay, so with that, I'd like to thank Ahmed, thank all the speakers in the first session. We'll have a break. We'll come back, inshallah, at 1 for 1300 military time for the next session, would be radiation. The lunch time would be at 12:15, and this is going to be behind us here. The doors will open at 12:15 for lunch. And there will be buses for transportation to Salat al-Jum'ah. And if the bus is full, another bus will come to pick you up. So we'll see you then. Thank you very much.
sterilized after neoadjuvant chemotherapy. It's all about radiation debate. My name is Amin Al-Umair. I'm one of the radiation oncologists. I'm the head section of general radiation oncology at King Faisal Specialist Hospital and Trade Center in Riyadh. Also, I work as a part-timer in Moosa Specialist Hospital. It gives me great pleasure to introduce someone who doesn't need any introduction, Dr. Shakir Shakir, the executive director of one of the major oncology centers in Saudi Arabia, King Fahad Specialist Hospital in Dammam. Dr. Shakir's contribution to the field of radiation oncology in Saudi Arabia is so evident. And the most peculiar thing about Dr. Shakir is the fact that he has tremendous amount of experience in organizing major event, annual Best of Astro. In my opinion, one of the best oncology, radiation oncology conference in Kingdom of Saudi Arabia, along with his colleague from King Fahad Specialist Hospital. Without any further ado, Dr. Shakir. So he'll be introducing the two speakers, then I'll take over. And after we finish, we'll ask the speakers to maybe sit down here and we can take a couple of questions.
Thank you for the nice introduction, my friend and colleague, Dr. Amin Al-Umair. As Dr. Amin said, a very strong debates in clinical scenario that might cause a lot of conflict in discussion. I will introduce the first speaker, my friend and my colleague, Dr. Taghreed Hindi, consultant radiation oncology at King Fahad Specialist Hospital. Dr. Taghreed.
Assalamu alaikum and good afternoon, everyone. I hope everybody had a great lunch. I'd like to thank the organizing and the scientific committee for this invitation. Myself and my dear colleague and friend, Dr. Reem Ajemi, will be discussing and debating about a very hyped up topic that came up end of last year, and we need to roll on through this. So should we irradiate or relax, okay, in those subset of patients? Do we need to give any local regional RT for patients who are diagnosed with clinical T1 to T3 N1 positive breast cancer who convert to N0 after receiving neoadjuvant chemotherapy? This is my disclosure. So in general, as a rule of thumb, regional nodal irradiation means that we're delivering nodal irradiation, whether it was post-mastectomy or post-lumpectomy. In post-mastectomy, we deliver it to the chest wall and the regional nodes, and in post-lumpectomy, we're delivering radiation to the whole breast, to the surgical cavity and the regional nodes. And this is definitely evident with certain definitive indications in the adjuvant setting. We know that regional nodal irradiation is well established and indicated for N2, N3 disease and many cases of N1 disease who harbor 1 to 3 positive lymph nodes. What we're doing is that we're effectively treating the nodal areas that were retained and not surgically dissected. Mainly that would be the supraclavicular, undissected axilla, and the internal mammary lymph nodes. Now, for early stage breast cancer patients who receive surgery as their upfront treatment, we do have abundant information about the rates and predictors of local regional recurrence with or without giving adjuvant systemic therapy. And this information has been used for decision for the radiation oncologist about the use of local regional radiation, whether after mastectomy or after lumpectomy. However, in contrast, we have limited information on the rates and predictors of local regional recurrence for patients who are receiving neoadjuvant chemotherapy. Neoadjuvant chemotherapy, we all know, has now become the standard of care and pretty much used in all patients who are presenting with locally advanced breast cancer and also the high-risk early-stage breast cancer, especially the HER2 positive and triple negative breast cancer patients. What's the effect of neoadjuvant is that it leads to local regional downstaging and distant metastasis risk reduction. Most of the studies, they still also demonstrated that after mastectomy and the local regional recurrence can still be observed after having pathologic complete response post-neoadjuvant chemotherapy, especially for patients who are carrying certain poor prognostic factors in their pathology, such as large tumor size. And we also know that patients who are going under upfront surgery, the benefit of giving them adjuvant radiation to the chest wall and the regional nodes is well established for patients who have positive pathological axillary lymph nodes. And so for us as radiation oncologists, we always go into this dilemma: what do we need to know? And when do we need to treat these patients post-neoadjuvant? We need to weigh which factors should drive the indication for regional nodal irradiation. What we're trying to do is looking at the clinical presentation and the pathological disease post-neoadjuvant chemotherapy. So the main variables that we're looking at that may increase the risk of local regional recurrence, in terms of the clinical disease at presentation, we're looking at stage 3 to 4, large tumor sizes, positive nodal stage, and young age as bad prognostic factors for local regional recurrence. And pathologically, we also are looking at the residual disease burden in both the breast, in the nodes, positive LVI status, triple negative disease as bad prognostic factors. And we're trying to balance and collect the risk of local regional recurrence in those patients to have a good indication for the patient to go for further adjuvant radiation. It's well established also that having a complete pathological response to neoadjuvant chemotherapy actually is very good prognosis for improved overall survival. And this has the strongest association in patients who are HER2 positive disease or triple negative breast cancer patients. If we want to look and try to clarify what are the risk factors for local regional recurrence, this is well established from the original study of B18 and B27 that has looked at the use of neoadjuvant chemotherapy. One of the combined analyses of this trial has factored in mainly 5 reasons for having a higher risk of local regional recurrence. The main things would be young age, high tumor size, clinically node-positive disease, having incomplete pathological response in the breast, and the highest factor that would be carrying out for a higher local regional recurrence rate would be YPN positive disease after neoadjuvant chemotherapy. But however, if you had a complete response in the nodes, they have actually shown to have a very low recurrence rate. So why are we discussing this in the background? Because one of the breakthrough, well-awaited trial, which is the B51 RTOG 1304, was released this year in San Antonio Breast Symposium. And this is a 5-year follow-up of this important trial, which is basically looking at patients who presented with a clinical T1 to T3 disease, N1 positive breast cancer. Obviously, these nodes were pathologically proven by an FNA or core needle biopsy. Patients received neoadjuvant chemotherapy, including anti-HER2, and then they went on to have surgery, and they had a negative axillary node. The type of surgery would have been either a sentinel node, followed by axillary dissection or an axillary dissection. The stratification of the patient was divided either to mastectomy or lumpectomy, according to the hormone receptor status, HER2 status, receiving adjuvant chemotherapy, and also looking at the breast pathological complete response. And so they were randomized to receiving regional nodal irradiation or no regional nodal irradiation. So if it was no regional nodal irradiation for patients who had a breast conservative surgery, they underwent only whole breast radiation. And for mastectomies, they did not receive any type of adjuvant radiation. However, if they were under the stratification for regional nodal irradiation, then both areas were treated, which is the chest wall, breast, along with the nodal basin. And so what they were trying to look at, the main primary endpoint of this result, of this trial, was to look at the invasive breast cancer recurrence-free interval. They did enroll a large number of patients, 1,500 approximately, and the median follow-up that we're looking at is 5 years. What they found surprisingly, and these are very good results, I believe, but let's look at what they have reported, is that they haven't seen any difference in the invasive breast cancer recurrence-free interval between the two arms, in the isolated local regional recurrence-free interval, in the distant recurrence-free interval, in the disease-free survival, and in the overall survival. So does this surprise us? Are these good results? Let's think about it a bit more deeply. How can we criticize this trial? And how can we really, can we just actually take these results and apply it in our practice? So first of all, who was enrolled in this trial? If we're looking at the distribution, they had a good distribution of patients, which is about 40% in younger age, less than 50. The tumor size for mainly were T2s, so 60% of the patients had a T2 disease. Only 20% were enrolled to have a T3 disease. About 60% of the patients had HER2 positive disease, whether they had hormone receptor positive or hormone receptor negative, but it's about 60% of the patients. There is a good division between lumpectomy and mastectomy patients. And the rate of pathological complete response in the breast was reaching up to 80%. And so, this trial had a good representation of mastectomy patients, which is at 40%. If we're trying to compare it to the other trials that are well known in establishing the role of regional nodal irradiation in the setting of upfront surgery, such as the MA20 or the ERTC 22922, which had a good percentage of mastectomy patients, definitely the B51 had a higher number of patients who received mastectomy. They also had more cases of HER2 new positive patients more than the other phenotype. We also know that these patients are more likely to receive neoadjuvant chemotherapy, and they're also more likely to achieve pathological response. We know the rates can go up to 60 to 70% in these patients. And so hence, they do qualify for the study. A potential selection bias could be that 80% of the patients in this trial, they had a complete pathological response in the breast. If we go back to the original trials of neoadjuvant chemotherapy, such as the B17 and B28, of those clinically node-positive patients who became YPN negative, only 24% of the trial patients achieved a pathological complete response in the breast. And so we conclude that practitioners were preferentially enrolling patients they felt were at very low risk of RT omission. Let's also analyze their forest plot and look at which criteria of patients favored having no regional nodal irradiation. The interesting part was that the effect of the tumor subtype, the least benefit was seen in the triple negative patients. So their hazard ratio was 2.3, favoring no regional nodal irradiation. And the most benefit was seen in the ER/PR positive HER2 negative, so the luminal subtype. And the overall p-value was very significant. So if we compare it, unlike the other regional nodal irradiation trials, as I have mentioned, where we have established the role for the benefit of regional nodal irradiation, we knew that triple negative subtype is one of the bad prognostic factors in which there was improvement in overall survival, such as the results that came out from the MA20, and they have allocated the high-risk node negative patients receiving regional nodal irradiation with having a potential benefit in overall survival. But the B51 apparently showed us an opposite result. The least benefit seems to be, as I said, in the triple negative breast cancer, and the most benefit of regional nodal irradiation was seen in the luminal subtype. Could this be also to the fact that these patients are selected for neoadjuvant chemotherapy and they also had pathological complete response? So unlike the luminal subtype where they would have less percentage of pathological complete response. Some other factors that were not mentioned in this trial, they did not stratify the patients according to the tumor size, and we know tumor size is an important prognostic factor. They did not even mention about the grading of the breast cancer. This was absolutely not stratified according to the biopsy grade. We don't have any data on mastectomy patients who only had sentinel node biopsy, because that is an option. They can have only sentinel node biopsy with a mastectomy. Why don't we have any data? Because those patients did not receive any radiation, and so we don't have any follow-up for these patients. Unlike the original trials, such as the Amaros and the Sinomac trial, actually those patients, when they had sentinel node biopsy, they were compensated with adjuvant regional nodal irradiation. So how can we compare both of these? I think that we still need more follow-up to see if there is improvement with regional nodal irradiation in the patients who had mastectomy and sentinel node only. We need to also criticize certain other points. Can we compare all clinical N1 patients and we say that they can all forego post-mastectomy radiation? Would a T3 N1 do the same as a T1 N1? Can they all be the same? Because this population is all taken together for the analysis of the trial. Would the size of the residual disease in the breast, whether this is a large residual disease or it's a minimal residual disease, can that affect our outcome? And can we compare a 1-node positive to a 3-node positive patient if we do a longer follow-up for these patients? So in summary, I think we need a longer follow-up, more than a 5-year data, especially for the ER-positive patients. We all know that ER-positive patients can have long-term recurrences, such as at years 15 or 20, and we need to await the final study results. In conclusion, in my opinion, it is too soon to know that the B51 trial should affect the practice. We still need some detailed results in relation to the type of surgery, so the combination of breast conservative surgery, mastectomy with a sentinel node or an axillary dissection, how does that affect, and where would be the role of radiation here? I believe selectively we may omit radiation in very early stage breast cancer who have favorable risk factors, who are older age, and we may give them RT to others until we have a mature data from B51. Thank you very much.
Thank you very much, Dr. At-Taghrit, for the comprehensive presentation. I will introduce Dr. Rima Al-Ajim, consultant radiation oncology at King Abdulaziz University Hospital. The mic is yours.
Assalamu alaikum and good afternoon, everybody. I would like to thank the organizing committee for inviting me to speak here today and thank my dear friend and colleague, Dr. At-Taghrit for making my task difficult. I'll be advocating for omitting radiation therapy after complete response for at least some patient with clinical T1, T3, N1 disease who end up having complete pathological response. I don't have any financial disclosure. I do have to disclose that I had no choice but to be in favor of omitting radiation therapy. So I'll start with a case scenario. So we have a 42-year-old female with a left breast palpable mass who ended up having a physical exam which shows that palpable mass in the outer quadrant with no palpable axillary lymph nodes. She had mammogram and ultrasound that revealed 2 masses in the breast, one in the upper quadrant and one in the lower quadrant, and thickened cortical lymph nodes with loss of normal morphology. She had a breast core biopsy that revealed a grade 3 invasive ductal carcinoma, ER/PR positive and HER2 positive, and the FNA of the axilla was also positive. So upon initial diagnosis, she was deemed as a T2N1 multicentric disease, and prognostically she had a stage 1B. So after discussion in the tumor board, she had neoadjuvant chemotherapy with double anti-HER2, and after completing her chemo on exam, she had residual mass in the breast but no palpable axillary lymph node. Imaging also revealed a significant but partial response in the primaries, but no abnormality in the lymph nodes. So she ended up having a skin-sparing mastectomy with a sentinel lymph node and immediate single-stage reconstruction. The frozen section was indeterminate, so the surgeon opted to complete axillary dissection. The final was YPT0N0. She had 24 lymph nodes removed. So she was brought again for discussion at the tumor board, and the question was, should we give her radiation or no? And I'd like to hear from the audience, who thinks she should receive radiation? Initially, it was 2.5 centimeter. Does she need radiation? No? I don't have to finish the rest of my presentation then. Halas. We're done. I convinced you. Okay, so the question we should ask ourselves is, what is the risk of local regional recurrence without radiation? And what is the toxicity of radiation therapy? Does the benefit truly outweigh the risk? Now, we as radiation oncologists always think of our treatment as an easy treatment. When patient comes to us after chemo and surgery, we say the worst is over, the coming is okay, and it's true most of the time, but we still give them some toxicity. It's not a treatment without toxicity. So I think we should de-escalate local regional treatment in at least some patients, such as this one, when they achieve complete pathological response. So like Dr. El-Hindi said, chemotherapy is increasingly being used for triple negative HER2 disease, even in the early stages, and there is excellent response to chemotherapy, which is associated with good outcomes. Again, the analysis that she spoke about of the B18, B27 chemotherapy trial, where adjuvant local regional radiation was not allowed, it was not popular at the time, showed that there are multiple variables associated with worse local regional recurrence. However, what stood as the most significant variable was the residual disease at the time of surgery. So they factored in nodal positivity at diagnosis with tumor size and response to chemotherapy, and they found out even for those who were clinically node positive and had tumors that are larger than 5 centimeters, if they achieve complete pathological response in the primary and the lymph node, their risk of local recurrence is actually 0 in these analyses, in these cohort. And that's not only that. The French also conducted retrospective analysis of 2 cohorts of patients, about 250 lumpectomy patient and 134 mastectomy patient. Both had complete pathological response, and they analyzed retrospectively those who had radiation versus not, and they found that radiation did not add any significant benefit. Again, this is an analysis of the database in the United States that looked at the overall survival with the addition of post-mastectomy radiation in patients who achieved complete pathological response. And they found that only those who had clinically T-stage, who had stage 3B or 3C at presentation, and those who had residual disease or had T3 or T4, those are the ones who had overall survival advantage from the addition of radiation. All others did not. Another analysis of the database now with more patients looked at the same issue, and they found that even those who had clinically N2 disease, if they had complete response, there was no benefit from the addition of post-mastectomy radiation. They analyzed those risk factors we talk about, including T3, T4, clinically N2, grade 3, and residual or triple negative disease, and they found that they were significantly associated with worse outcome in those who are node positive at the time of surgery. But if they had complete pathological response, all those factors are not significant anymore except for triple negativity. This is a report from China that was presented in ASTRO a few years ago and then published, and they looked at large cohort of patients. The good thing about this one, it also has information on their HER2 status, because the older trials did not have information on that. And although not all patients had anti-HER2, they found out that those who had N0 at the time of surgery only benefited from additional local control, which was even without radiation therapy, the local regional control was well, like in the 90s, so the recurrence was well below 10%. There was no advantage in terms of disease-free survival or overall survival from the addition of radiation. However, those who had N1 disease at the time of surgery after chemotherapy had significant improvement in local regional control, disease-free survival, but not overall survival except for the ERPR negative and stage 3 disease. Those who had N2 or 3 had improvement in disease-free survival, overall survival, and obviously local control. Again, like I said, the older trial did not factor in HER2, so this is analysis of two systemic treatment trials where they looked at the patient whose radiation was left at the discretion of the radiation oncologist, and they analyzed their outcome. So they found out that the factors that were associated with worse outcomes are N3 disease at presentation, or incomplete, like loss of nodal complete response. The radiation therapy did not have any benefit as an independent factor. They also, in the same study, looked at those who had complete pathological response, and they found out their local region recurrence-free survival is 97% regardless of whether they received radiation or no. This is a very nice prospective registry that was done by the German. So basically, they prospectively analyzed, and it was not randomized, so this is a prospective registry, but they put guidelines to follow. And in these guidelines, they categorized patients into low risk, intermediate, and high risk. And the low risk patients were either those who had axillary dissection and had complete response, or had sentinel lymph node with complete response, and then they did not have grade 3 or LVI or larger tumor size, because they thought sentinel lymph node is not as dissection. So to be more comfortable to be in the low risk, they had to have not to have other features as well. And what they found out was those who had complete response, those who had low risk disease, which is complete response, and they had excellent outcome without the radiation. So their recurrence was 2.3%. And because it was only guidelines, not a set protocol, so some did not follow the trial guideline. But they found that even with that, they looked at those who did not follow the trial guideline and gave radiation. The risk of recurrence in those was 1.9%. So really, there was no difference whether radiation was given or not in this subset of people that are very low risk. Now we come to the NSABP trial, which my colleague discussed thoroughly. I have to say that for a while, I've given few presentations before about the role of radiation in neoadjuvant chemotherapy, and we're almost convinced that we don't need it, but we're waiting for the randomized trial. But somehow now that the randomized trial is here, we're still not convinced. So this is a good trial. They had representation of all age groups or races, ethnicity. Tumor size was equally distributed between arms. 20% were T3. Regarding the classification characteristics, subtypes were all included. Patient had the good presentation of mastectomy patient, like my friend has already mentioned, and PCR was significant. So no additional benefit in terms of disease-free survival or overall survival or recurrence-free survival from the addition of radiation therapy. In fact, the study is already mentioned in the NCCN guidelines. So if you see here, for those who are N0, they strongly recommend to consider radiation treatment. However, they acknowledge that there is a subset of patients that does not need radiation. And this poll was done in the internet by the MedNet group. And as you can see, there's a 30% that want to wait for more follow-up, and 15% that are very comfortable with emitting radiation today. However, there's a 53% that will continue to offer it depending on other risk factors. And I think this would be very reasonable, and that's what I want you to be convinced with today. I mentioned toxicity, so briefly I would like to remind you what are potential toxicity of radiation. So lymphedemas, particularly after axillary lymph node dissection, is a significant issue. So they have about 30% risk of developing lymphedema if they had dissection and radiation, 24 if we omit radiation treatment. If they have sentinel lymph node without radiation, the risk of lymphedema is as close as no surgical treatment at all for those patients who are DCIS and only receive radiation. Another important toxicity is cardiac toxicity. Now, the risk of cardiac toxicity we thought about as being a late toxicity, but 10 years ago this paper was published and they confirmed that they can have increased risk of cardiac morbidity as soon as after radiation treatment, and it continues for years afterward. Now, it's a relative increase in risk depending on their initial risk factor, but it is something to worry about, and we do a lot to decrease the hard dose in our treatment. This is another study that looked at cardiac disease in general for breast cancer. They factor in chemotherapy, hormonal therapy, and radiation. And they found out the radiation does increase the risk of cardiomyopathy and heart failure. Now, it is statistically significant. It's 1%, which a majority of time would be considered negligible. But when the risk of local recurrence is 2% and the benefit is really minimal, then 1% risk of cardiac toxicity is not negligible anymore. Last thing is implant failure. Like I said, it is something that we usually consider not important if the benefit of treatment is huge. I do quote to my patient that there is about 30% risk that she will end up having another surgery because we know that reconstructive failure increases with the addition of radiation treatment. Most of the time, that's not a huge concern because the benefit is high, but when the benefit is low, we should really look into our treatment options. So my summary is that we should de-escalate local radiation in at least some patients with clinically 2 and 3 and 1 who end up having complete pathological response. Thank you very much.
That is wonderful. Thank you very much, Dr. Reem and Dr. Taghreed. The floor is open for maybe a couple of questions. So I do have a quick question. So just being not treating breast cancer a lot. Well, I have one question for Dr. Reem. So just curious to know, first case you showed us HER2 overexpression, 2.5 centimeter at presentation. Why mastectomy? Oh, multicentric. Okay, makes sense. Make a lot of sense. It's just curious. I thought it is a question. Hey, تفضل Mr. Mustafa Mubarak.
Thank you very much. Assalamu alaikum. Just I'm a medical oncologist. I have a question regarding a different scenario. I mean, when you irradiate T2N0 after mastectomy, because I had a case, same scenario, T2N0 at 4.2 centimeter and LVI positive and grade 3. So we did not send her for radiation, just given adjuvant chemo and then hormonal. 4 years later, she had local recurrence.
So post-mastectomy, sir?
Post-mastectomy, yeah. So that's maybe not related to your present, but just...
No, it's a very good question. Who want to take it? We have two experts.
That's a very, very nice question. Obviously, your scenario does not apply to this case because you had an upfront surgery, an upfront mastectomy, basically. And what we're looking here is an indication for high-risk node-negative post-mastectomy radiation. Definitely, yes, this is a T2N0, but we do combine a few bad prognostic factors here. So I don't know, probably maybe she was young or something, but having a grade 3 and LVI positive especially actually has a very high risk. It reaches up to 20%. And whenever in radiation, actually, whenever we have percentages reaching up to 15 or 20%, this is a good indication to give radiation. So definitely this is one of those scenarios where we discuss the option of giving post-mastectomy radiation as a case of high-risk node-negative chest wall RT. Yes, it is not a definitive indication, as we have learned, such as having 4 or more positive lymph nodes, positive margins, or having a clinical T4, T3 disease. But in these cases, we definitely discuss the option of giving radiation, and we combine these risk factors. So this is what we're trying to debate here, because all our data that we know for having bad prognostic factors come from these upfront scenarios when we had the surgery as the first line of treatment, and then we look in the pathology, and then we compare for those patients who's going to have a higher chance of local regional recurrence. But now this is what it's making it more difficult for us as radiation oncologists, is that post-neoadjuvant chemotherapy, we have more complete response, especially for the HER2 new positive patients or the triple negative. When do we need to omit that? So yes, it's correct that the patient may have omitted radiation or that was not given, but as you can see, that recurrences can happen, and probably if she had radiation, that chance would have been lower.
Thank you very much. Yeah. So, Dr. Mustafa.
I mean, this makes me surprised that you are omitting radiation for very high-risk patient, and then after neoadjuvant chemo, BCR. I mean, that's make me surprised.
Most of us, we discussed with Dr. Mustafa, not feeling comfortable in omitting radiation based on abstract, but this leads us to the next question, I want one case scenario that maybe Dr. Reem and Dr. Tagreed consider the most scenario you will omit radiation, patient characteristic, and another scenario that you will not omit radiation. طبعا you cover it nicely in your presentation based on receptor status, so forth, but just let's summarize it based on Dr. Mustafa's question.
So I'll give you a scenario where I would definitely give radiation. So if I have a patient, 35-year-old with a triple negative 7 centimeter or 8 centimeter, who ends up having mastectomy with sentinel lymph node with complete response, I would offer adjuvant radiation.
Interestingly, in the trial, but this is not significant, triple negative, giving radiation was detrimental, but it's not
I think
very small number of patients.
Plot and I don't think this is significant. I don't think we can throw away all the body of evidence we have about triple negative disease for one trial. I think you can't just rely on this.
Correct. So young age, large T3, triple negative receptor status, sentinel lymph node as opposed to axillary dissection. You will give radiation.
Yes, no, I don't do this with all sentinel lymph node, but this is one part where I definitely would want to see the full publication before I rely on, because I'm not sure how many of those had targeted axillary dissection versus just simple sentinel lymph node with 2 lymph nodes removed. So I'm comfortable emitting radiation in certain patients who had axillary dissection at this point, but for sentinel lymph node, I'd love to wait and see the full publication.
Excellent. So let's show up hand, Dr. Shakir, Sameh, Zaid, Dr. Jamila, would you agree that you will not omit radiation for this high-risk patient? Yeah, I agree, Sam. Yeah. Dr. Tagreed?
Exactly. I mean, I absolutely agree with Dr. Reem because I would do the same.
This is Dr. Mustafa Mubarak point.
And the opposite to that, for example, the scenarios where I would think of omitting radiation would be very similar scenario to the case that Dr. Reem presented. So older age, let's say 60, 50 or something, okay, with a very small T2 or a T1, of course, because these were all included in the B51, and they only had an N1 disease, had a full axillary dissection, or even a sentinel node, let's say, but their luminal subtype, I think, giving those factors, we may omit. Excellent. Because they're still considered as stage 2. So classically, we all know that stage 1 and stage 2 are the least, cases of patients who would benefit from post-mastectomy radiation, regardless of the combination of the other, biological and pathological factors. But definitely, I would always discuss these cases with the patient and get a mutual, decision on treatment. But I believe, as I have mentioned, that we only have a 5-year trial. And for trials that pertain to the practice changing in breast cancer, we need to have longer follow-ups because recurrences can happen later on.
Dr. Zaid, just in here, because we're running out of time. Can he have my mic? Zaid is one of the radiation oncologists in Jeddah.
Thank you. Some of you answered the question, but if you have two patients, both of them are 50 years old, T2N1, which one of them is triple negative, who received neoadjuvant chemotherapy. The other one is luminal A, which will go with upfront surgery, definitely. The luminal A is a T2N1, 2 out of 8 lymph nodes positive. The other one, she had a complete pathological response. Would you treat both the same? With the fact that the triple negative, she received neoadjuvant chemotherapy, and according to the P51, she will be omitted of giving radiotherapy. The other one, she is N1, and you will not feel comfortable not giving the radiation.
Honestly, I know it is very counterintuitive when we're trying to analyze results from upfront surgery versus post-neoadjuvant chemotherapy, because we have well-established trials for the upfront surgery. We are deriving now the benefit of regional nodal irradiation after the ERTC and the MA20 trial, and that's why we're doing it. We know that there is no improvement in overall survival, but definitely there is improvement in disease-free survival, and hence it has been easier for us to give radiation for all N1 patients. But to be honest, if you actually go in depth into all the retrospective studies that have looked at N1 disease, it was never a definitive indication for giving post-mastectomy radiation. I'd say 50 years old, this is a middle age. She's not very old. In my practice, honestly, I would give her radiation based on the results of the ERTC. For the triple negative, I would still give her because she's triple negative. Yeah.
Correct, yeah. طيب, Ahmed.
Just a comment. I struggle with risk stratification for breast cancer in those who have complete response. Because we know in HER2 positive, for instance, if they have an advanced disease to start with, and then they go into complete response, the risk of relapse is much lower than. Now, the problem that I face with radiation is that you guys almost always stick to the pre-treatment regardless of the response. So, in my opinion, the mindset has to change from medical oncology as well as from radiation oncology. And we have a clinical trial that tells us otherwise, but still most of the radiation community believe that we still have to go by the pre-treatment staging and make the decision based on that. So, comments?
I think we as radiation oncologists we have difficulty adopting new practices. I agree with you. Now, like I said in my presentation, we've been saying we're waiting for a randomized trial. Now that we have the randomized trial, we're still debating whether or not we should give radiation. It's very difficult, like we were discussing earlier. We're convinced, but it's just difficult not to treat. To say that, no, you don't need treatment is very difficult for us somehow. But we should change. This should change. We should select these patients who are earlier HER2 positive and they do excellent and they have a very low risk of recurrence. I think we should spare them radiation.
I agree with you. Moving from breast to lung, quartz trial, whole brain metastasis, no benefit. Everyone is doing low-grade glioma observation. No, everyone is giving radiation, although there is randomized level 1 evidence, 2 randomized trial, European and American. So almost we're running out of time, but let's move from axilla to IMC. Dr. Sam and I have a couple of cases in Moosa Hospital where patient need PET scan for other reason, had FDG avid, IMC. Chemotherapy, complete response. طبعا, this is a metabolic complete response, radiographic complete response, not pathological. We did 2 cases. One case, maybe I'll ask the radiation oncology group. So I know Dr. Reem practices, it's like my practice. So are you going to treat IMC after neoadjuvant chemotherapy, PET scan, complete response in the IMC? In CT scan, you can't see anything. It's just gone. Would you include IMC This is the first question. Then, would you give just microscopic dose or you will boost it? So, who want to take this? Tagreed, you are the expert.
I'll take it. If I had a positive internal mammary lymph node that was evident on the staging scans, yes, I would treat it with only a microscopic dose, even post-neoadjuvant chemotherapy, up until now. Unless I do face certain problems with the planning constraints, then I may think of omitting it. Again, taking into scenario the age of the patient and the other bad prognostic factors. Because, I mean, yes, we are able to plan the patients with an internal mammary at the expense of increasing the doses to the heart and to the lungs. So I'd have to weigh the benefit to that. But definitely, any involved internal mammary, I definitely try to treat those. If it was not involved and then I'm treating it prophylactically, then it's a question whether I want to add it or not.
So it's even. So you do like Dr. Sameh. I do like Dr. Reem. We boost we don't feel comfortable because it's like not pathological complete response. So Dr. Jamila, we have three. Zaid, Dr. Zaid, Dr. Jamila, Dr. Shakir. We need to...
if you allow me,
anyone will not treat because complete metabolic response?
If you allow me, I have a couple of cases with Dr. Tagreed that we that we have a positive initial gross internal mammary node. So after neoadjuvant, we give, still there is a kind of metabolic response, but we still could we evaluate that there is a residual morphological node. So we boost it with standard dose hypofractionated, and then we give a boost to the local residual disease, 16.5 in 3, as in
so you'll boost. So
however, but as Dr. Tagreed said, when there is like no visible disease, we give just only microscopic dose.
Sure.
Yes. If I see any residual node, then I boost
No,
it.
it's complete response. Nothing in CT. Dr. Jamila, do you wanna? What's your practice? IMC positive and on PET, and then after neoadjuvant,
Dr. Maimouna, not Jamila, sorry. That's why I was looking for somebody.
طيب نسأل دكتور زيد. Excellent. So by this, we conclude the session. We'll not talk about supraclav. خلنا على Excel or IFC. Thank you very much to the excellent speaker, and thanks for your attention.
Thank you very much.
Luai.
Ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. I'm glad to be a part of this conference, which is held by Moosa Health Group. I want to extend my gratitude to the organizers and the sponsors for this successful meeting. Moving to our next part in the agenda, as we know, the auxiliary management has been changed recently. Now we are in the era of de-escalating the surgery for the surgical management. Our next topic is the management of the axilla in the modern era by Dr. Mohammed Ad-Dahalib. Dr. Mohammed Ad-Dahalib, he is a consultant, breast and endocrine surgery and King Fahd Specialist Hospital in Dammam. Please join me welcoming Dr. Ad-Dahalib to the stage.
Assalamu alaikum and good afternoon, everyone. And thank you so much, Dr. Luai, for the introduction. Thank you so much, Al Moosa Hospital and Dr. Ahmed Al Wabari for giving me this step. It makes my life difficult. And thank you, Dr. Reem and Dr. Tagreed, for making my presentation easier to make the flow clear. So, Dr. Ahmed, smart thinking of putting this schedule in this orders. So let me check it. I have no disclosure, and I used to start with reading some history before jumping to the future. Without reading in history, I think everyone will start from the scratch and will start from the beginning. So we have to know exactly where the people stands to go from there. So the axillary management is very important in the breast cancer treatment, and it's a predictive and prognostic procedure usually. It's not a therapeutic in many of the scenarios with the patient. So we have to know that the initial management of breast cancer early in 1970s started with axillary lymph node dissection, regardless of the status of the nodes. And then the evolution of the assessment of the nodal status extrapolated from the melanoma patients, where the sentinel lymph node biopsy as a procedure was succeeded in these patients, and then it was replicated to be implemented for breast cancer cases. And then from there, we know that by the NCABP B32 trial, we know that the sentinel lymph node biopsy is an effective and the modality of assessment of the axilla for node-negative patients in comparison to the axillary lymph node dissection, and I will go from there. This is, as usual, this is the take-home message. I usually start with it, and then I will elaborate more in this presentation. And then, early in 2000s, the sentinel lymph node biopsy, in collaboration with the radiation oncologist, came with the Z11 trial and Amaros trial, and I will come across this. And for patients with improvement of neoadjuvant, with the phenotype of the breast cancer, we know that many of the patients will respond aiming for PCR in these patients. And then hence the Alliance trial, the Z1071, Sentina and SNFANAC came there. And nowadays, recently last year, just a few months ago, the SOUND trial came for patients of, shall we still do sentinel lymph node biopsy in certain circumstances, or we can omit the sentinel lymph node biopsy? So this is the journey of my talk. I'll go briefly about the epidemiology, and then what is sentinel lymph node biopsy, what do we do in the surgical field. My talk will be divided into two types, or into two parts. The first part in upfront setting, where the patients were discussed in the multidisciplinary meeting, and then we decided for upfront surgery. The second part will be about the axillary management post neoadjuvant chemotherapy, and lastly, I will talk about the possibility of omission of sentinel lymph node biopsy in certain circumstances. We know that breast cancer happens in 1 out of 8 ladies. This is in USA, and the prognosis of these patients will depend on staging, and we know that we use the TNM staging on these patients. And it's very important to focus that the lymph node involvement, I can't point it here, but we can see that the stage and the overall survival, the 5-year survival of these patients will decrease with the stage of the cancer. We know that the lymph node involvement is the most prognostic factor determining the prognosis of these patients. Not only this, with the new development of the knowledge for breast cancer, we know that the phenotype plays an important role. This is why, as mentioned by Dr. Reem, that we have the anatomical stage versus phenotype and the biological staging, having triple negative and HER2 negative carrying poor prognosis. Yet, still, until now, the sentinel lymph node status is the most important prognostic factor for breast cancer. It provides predictive and prognostic value for patients. So what we do usually in the surgery, just to give you a hint of the procedure itself, usually the sentinel lymph node biopsy, it's the guardian for the axilla. Usually it's the first lymph node that drains the organ, that drains the tumor, and then most likely it harbors the tumor. Usually there is no skip lesion in breast cancer. This is why we are looking for the sentinel lymph node biopsy as the first lymph node. We can use multiple modalities. We can use usually methylene blue, tattooing this lymph node, or we can use indocyanine green, or sometimes nuclear material like technetium-99 also. With these different modalities, I have to mention about the B32 trial that make an important shift in the treatment of the axilla. Previously, all the patients came with breast cancer will be treated with axillary dissection initially, regardless of being node positive or negative. And then with this trial, they proved that, or they randomized the patients into two groups. The first group underwent only sentinel lymph node biopsy, sentinel lymph node biopsy plus axillary dissection, and the other group underwent only sentinel lymph node biopsy. And they found that the false negative rate for the patients underwent sentinel lymph node biopsy alone was less than 10%. And we have to remember this number as surgeons or as a healthcare provider for breast cancer. We are aiming for a false negative rate less than 10% as a benchmark for this nodal assessment. So anything above 10% is unacceptable. We are trying to lower the false negative rate of leaving positive disease in these patients less than 10%. And they found that there is no statistically significant difference in overall survival and disease-free survival for these patients. So from there, we know that the sentinel lymph node biopsy procedure is the standard of care in patients with a clinically and radiologically node-negative early-stage breast cancer. So what do we do when we have a negative sentinel lymph node biopsy? I'll tell you that it's a positive sentinel lymph node biopsy, regardless of the number. What you will do? Whom with the dissection? Thank you so much. Tagreed, I know you, okay? That's fine. So this is the classical teaching. Many questions should be put in mind in this stage. Is this patient going for upfront surgery or post-neoadjuvant chemotherapy? Is this patient expected to have PCR or based on the molecular subtype of the disease or no? So many things should be put in consideration for these patients. And from there, I will take the discussion. Dr. Lai, count for me, please. I don't know how much time. This is my talk. That was only introductory for to take you up to this point. And then I will start with the patients going for upfront surgery. What are the trials? Remember, just Z11 and Amaros for patients. The Z11 trial is the American trial, while the Amaros is the Netherlands European trial. And from there, this is the Amaros trial. It's non-inferiority trial. Okay, and this is the trial profile. They have, all patients went for sentinel lymph node biopsy. If you have one or two positive node in the sentinel lymph node biopsy, they categorize or they divided patients into two arms. The first arm going for surgery, the second arm, no surgery. They dissected versus no dissection. No further treatment. This is the Z11 trial, and usually the criteria for Z11 is early stage breast cancer, going for lumpectomy only, not mastectomy, and then patient is not contraindicated to receive radiation post-op, will receive adjuvant if required, and the result of this trial was that having low burden positive disease, by numbers, one or two positive cancers, lymph nodes or positive nodes, you can omit dissection safely with no statistically significant difference in overall survival and disease-free survival for both patients. Not only this, the extended 10-year assessment of these patients by Alliance was reported, and again, it is consistent with there is no statistically significant difference in low burden disease in the sentinel lymph node biopsy. In upfront surgery for early stage breast cancer, going for sentinel, if you have a one or two positive nodes, you can still omit dissection safely with no statistically significant difference in the overall survival and disease-free survival for longer duration of follow-up of 10 years of Alliance. This is the American school. What about the European school? Again, it's consistent with that. Despite this, the amorous differences with the Z11 in comparison to the Z11 trial was that they did not compare the non-surgical versus surgical. They compare surgery versus radiation in the amorous trial. Okay, and the other thing is that they included patients undergoing mastectomy, yet it's only early stage T1 or T2 breast cancer going for mastectomy for other indications. Again, the amorous trial were divided, as I mentioned, either for axillary dissection versus radiation, and the result was consistent with the amorous also. There is no statistically significant differences between the overall survival and disease-free survival in the amorous trial. So we know that, to conclude the upfront setting, if you have a clinically node and radiologically node negative disease in upfront setting, you can still assist these patients with sentinel. Yet, if they have 1 or 2 positive disease, you don't need to dissect. You can give radiation post-op, and this is the NCCN guidelines criteria. Nowadays, they are integrating 1 to 3 nodes in the latest version of the NCCN guidelines, but there are more details. Yet in our practice, I do 1 or 2 positive until now. I'm not comfortable to leave patients with 3 positive node without dissection. It depends on the phenotype, for sure, but I'm still with 1 or 2 positive. I will omit the sentinel lymph node biopsy in upfront setting. So let's have a look on the axillary management post-neoadjuvant. So these patients are very important to divide patients into patients initially was node negative, okay, initially node negative, and the patients whom are initially node positive. So if you have a patient the positive node before starting chemotherapy. We have 3 landmark trials on these patients. We have the Z1071, we have the Sentina, and we have the SNFA-NAC, which is the sentinel node following neoadjuvant chemotherapy. All of them, I will not go through them all, just this is the trials, and then I will go to the conclusion immediately of these 3 nodes. This is the these are the studies evaluating the identification rate and the false negative rate of this trial, but the conclusion of this study, after addressing all the false negative rate, just focus on that. I put this slide, it's a busy slide. I hate putting busy slides. I want you to focus on the false negative rate. And there are many questions, and I ask my resident these questions. Let's think about it. What you can do to minimize your false negative or to decrease your false negative rate in the procedure. If you remove one lymph node, the chance of leaving positive disease is still high. So what you can do to decrease this false negative rate is by increasing your number of the sentinels. So instead of taking 1 sentinel node, you take 2. If you take even more 3 nodes, this will be even more successful of decreasing your false negative rate. What else? The other thing is that having dual tracer rather than single tracer. Again, the Z1071 was consistent with this, the false negative rate less than 10% by using dual tracer, by retrieving more sentinel lymph node. Also, the SNFNAC also was consistent with the result. This is the summary of the 3 trials. All of them were consistent with false negative rate less than 10% when you use dual tracer, and if you retrieve at least 3 nodes at the time of the sentinel lymph node biopsy. So this is the conclusion of these trials that you have to do. So we know that we have 2 groups of patients. The first group was upfront surgery, patients post-chemotherapy, and we have 2 subgroups of these patients. Patients initially were node negative, patients were initially node positive, and we revisited the axilla after neoadjuvant chemotherapy. The question at this time is, can we omit actually sentinel lymph node biopsy or no? Are we brave enough to ignore the axillary surgical assessment as predictive and prognostic value by not tackling the axilla at the time of the surgery and leaving it? This question came, it's a very difficult question actually, but let's take it also again, reading by history. 2012, the Choosing Wisely, it's an initiative started by internal medicine. Choosing Wisely is not a guideline. Choosing Wisely is an initiative about to choose the proper treatment, the proper investigation for a proper patient. So you have to tailor your treatment according to the scenario of the patients. It's not only for cancer, it started for diabetes, started for many medical disorders. One of them was cancer initiative, and under the umbrella of the cancer was breast cancer. So many of the institutions internationally integrated. This is one of the articles, measures the appropriateness of applying the Choosing Wisely in breast cancer cases. Still, they are trying to address if it is applicable or no. And then this is another trial, was published in JAMA. So here, where the Society of Surgical Oncology finally give their guidelines about choosing wisely in breast cancer. So again, I think Dr. Wabari and Dr. Taghreed, Dr. Reem, you mentioned about risk stratification. So again, we are stratifying our patients. We know that patients, elderly patients, clinically node negative. So let's read it. I think it's better to read it to fragment the information. It's to omit the axillary dissection. Don't routinely use sentinel lymph node biopsy in clinically node negative, clinically and radiologically node negative patients. Ladies more than 70-year-old. So if she is, I would say the performance status will play a role on these patients, okay? With early stage, should be early stage breast cancer, hormonal positive, HER2 negative ladies. In these ladies, you can omit, and we are applying this in our patients. Not only this, I think the latest thing was the sound trial, where also they are thinking of, regardless of the age of the patient, node negative or even node positive disease now, regardless of the age, you might omit the dissection according to the criteria. So I think this is the new era of, I totally agree with you, Dr. Arim, de-escalating the management of the axilla. So by this, I would conclude my presentation that sentinel lymph node biopsy, identification rate, and false negative rate in node negative disease is similar to those with initially sentinel lymph node surgery. The nodal recurrence after a negative sentinel is uncommon in these patients. So in patients with a clinically node positive disease, the sentinel lymph node biopsy after chemotherapy should be accompanied by having dual tracer, retrieving at least 3 nodes disease. And by this, I would conclude my presentation. Thank you.
Thank you very much, Dr. Adhalib, for your enlightening presentation. Please have a seat. We are going to take a couple of questions before next presentation. تفضل Dr. Ahmed.
Thank you for this excellent presentation. I have a question. If you have a patient clinical node positive and T2 and she received neoadjuvant chemotherapy and HER2 positive, يعني neoadjuvant therapy, and then after surgery, dual tracer 3 lymph node, 1 is positive only.
Okay.
So do you recommend dissection or no?
Yeah, let's take it from this. I think it's very important to speak about the presence of positivity. Is it isolated to tumor cells? And we have to note, I did not go through it because Dr. Ahmed put me in tight position. I have no time for this, but isolated tumor cells, micrometastatic positivity or macrometastatic in upfront setting is totally different in post neoadjuvant. I would say, I'm considering Dr. Ahmed, you are talking about
macrostatic, but 3 lymph nodes, only 1 is positive.
Anything positive, that means we lose the chance. It's not a PCR, it's a predictive. Yet, the problem is that it's positive, so you as an oncologist would know exactly, is it pathologically N1, N2, or N3. So without dissection, I would not label the patients or stage the patient properly post-op. So I'm forced to dissect in these patients, yeah.
Okay, thank you.
For staging purposes, not for therapeutic purposes, yeah.
Thank you, good afternoon. I'm Dr. Susan, I'm a radiologist, and I need to ask a question. Before I was attending like online session conference, and one of the doctors, oncology surgeon, said that there might be a new practice that when we diagnose a patient with tumor and lymph nodes, and she's going to have neoadjuvant chemotherapy, we can do, after the MRI, after the PET CT, I mean before the chemotherapy, we can do like a tattooing for every enlarged or pathologically looking lymph node. That might help that when they regress to the normal size, because sometimes on the follow-up, they all revert to normal shape. So when you go for the sentinel lymph node, you don't just take the sentinel lymph nodes by methylene blue, you can also take the previously infiltrated nodes. Would this help in practice in reducing anything related to radiation, or in making sure that you just pick up the nodes?
Thank you so much, Dr. Suzanne. I think this is a very important question again. There is an entity called TAD, or Targeted Axillary Dissection. And TAD, what we mean by TAD is that we mark the positive node before starting the chemotherapy by help of you, the radiologist. So labeling these patients by putting a mag trace, which is a magnet trace, or we put a marker clip, the metallic, usually titanium clip, or even by tattooing these nodes. Okay, the problem with these patients that we don't know the response of the lymph node. It's different than the breast. The physiology of the lymph nodes and the lymphatics is different. The axilla is full of fat. So what happens, the migration rate of the marker clip, the fibrosis, the loss of the tattooing is different. But it's still yet well studied that TAD will minimize the false negative rate. So not only retrieving the 3 nodes, not only using dual tracer, if you have the capability of retrieving the positive, we need to retrieve this node. Yeah? For me as a surgeon, for us as treating physicians, we need to know if this positive node before neoadjuvant responded completely or not for chemotherapy. So if we are assuming that it is the sentinel node, but it's not the scenario all the time. So if I have the chance, so for the surgeons, how many surgeons here in the okay, thank you so much, Dr. Obari. By the way, he is my professor. Okay. The definition of sentinel lymph node biopsy in the field. For example, Dr. Luay is opening the axilla and we inject blue dye. I always tell my trainees is that the sentinel is either blue if you inject blue dye, hot if you inject technetium, green if you inject indocyanine green, or clinically suspicious. You have to mention this. You have to put your finger in the pectoralis major, subscapularis, up in the apical lymph nodes. You have to make sure that you are not leaving any clinically suspicious node. Trying to minimize your false negative rate less than 10%, trying to not to leave any positive lymph nodes in the field. So I agree with you. Targeted axillary dissection, yes.
Thank you so much.
Thank you.
Any further question from the audience, please?
Does it have a question?
Dr. Maruqa.
Yeah, sorry, it's a comment and a question at the same time. So going to the choosing wisely for the elderly patient more than 70 years, actually it's funny, in those cases actually we omit radiation. So once you cancel the sentinel lymph node, so should we go back to giving radiotherapy? So which is worse, doing sentinel or giving radiotherapy?
Okay. The question came by reading history again. The question or the idea came from how many patients, let's take it fragmented from their statement. They mentioned early stage. So yet they are eligible for what? For Amaris or Z11. Okay, so what is the chance of clinically node negative to have frozen or final pathological sentinel positive, regardless of the number? It's very low. It's reaching up to 5% maybe. So out of this 5% positive sentinel, me as a surgeon, how many of these I will dissect? Even less. So it's extrapolated from the DCIS trials initially when you come to it. So the question is the chance of having positive axilla in these patients is very minor and very low. So this is why it's not a guidelines yet. The sound trial was proved even for node positive disease, yet you can omit the sentinel lymph node biopsy. So it's very difficult question. Maybe Dr. Taghreed and Dr. Reem can help in the radiation point of no sentinel assessment, what to do from the radiation point of view. In the multidisciplinary, we have all this argument together usually, yeah. So Dr. Taghreed, yeah. Taghreed.
Last question, please.
Dr. Luay, Dr. Taghreed has a comment.
We'll receive last question, please.
Yes, so we do get into the scenario, Dr. Sameh. What we do is I'm basically treating them as a node negative patient. So if they had a mastectomy, no treatment, and if they had a lumpectomy, I just treat whole breast and I give them fast forward. Yeah, basically the idea is that I'm treating them as a node negative. I don't go back and dig into the history and say that the patient may have had a node positive and we don't know and the patient did not have any surgical assessment. No, I just treat them blindly as a node negative because we know the recurrence risk is very low. As you said, most of these patients are eligible for omission of radiation.
Yeah, and by the way, they should be, according to the choosing wisely, they should be luminal. So we know that the phenotype is less aggressive than the usual.
Thank you very much, Dr. Adhalib. By this, we conclude our session and we move to the next presentation. Thank you very much.
شغالة. Good afternoon. My name is Dr. Suzanne Farou. I'm a radiology, breast imaging and intervention consultant in Moosa Specialized Hospital. On behalf of our department and on behalf of this amazing conference, I would like to present Dr. Abdul Latif Al-Sharif. He's a professor and senior consultant of nuclear medicine in the Department of Radiology and Nuclear Imaging, University of Jordan, Faculty of Medicine. Dr. Abdul Latif founded the Service of Nuclear Medicine at University of Jordan and Jordanian National Cancer for Diabetes and Endocrinology. And most recently in Al-Moosa Specialized Hospital. He worked as a part-time in Al-King Hussein Cancer Center as well. He graduated from University of Jordan, holds the Italian Board in Nuclear Medicine and Molecular Imaging, and has advanced training in PET-CT in Stanford University, with many publications and in journals and textbook chapters and more than 30 abstracts. I would like to welcome him to talk to us about the molecular imaging in breast cancer, a very nice topic, and I know you will enjoy it. Thank you.
Thank you, Dr. Suzanne. Thank you, everybody. Thank you, Dr. Wabari, for inviting me to this presentation. So, to take it short, let's start. My topic will be about molecular imaging of breast cancer, and of course it will be about PET scan. I'm not be talking about sentinel lymph node. I think you all know better than me the sentinel lymph node and bone scans. So let's start. Now, in terms of molecular imaging of breast cancer, we have two very important tracers, which are the FDG PET and the sodium fluoride PET. These are the FDA-approved PET tracers for imaging of breast cancer. And more recently, there is another FDA-approved tracer, which is the estradiol PET that is dedicated for imaging of estrogen receptors. So let's start going through these tracers one by one. Other tracers are in the cockpit of nuclear medicine. Most importantly, there will be FAPI, and I think most of you will start hearing about FAPI PET. And it will be really very important tool in breast imaging in the coming years. Also, the epidermal growth factor, the HER2 receptor PET, is coming, and it will be soon, I think, within few years, it will be also in the clinical market available. Now, before we go through PET, I have to remind you what is the pathophysiology of PET, FDG PET as we know it. It is imaging of glucose metabolism inside the tumor, where glucose is known to have where the tumor has the Warburg effect, and the Warburg effect is characterized by aerobic glycolysis of glucose, where glucose is consumed by high amounts due to inefficient metabolism inside the tumor cells, leading to high consumption of glucose, where one glucose molecule inside the tumor leads only to 4 molecules of ATP, contrary to the normal cells which produce 36 molecules of ATP. That's why the cancer cell usually uses lots of glucose for metabolism and to build itself. Now, when do you use FDG PET in breast cancer? Not all and every breast cancer must go through a PET scan, FDG PET scan. Of course, we can't use PET to diagnose non-invasive breast cancer. It's not our role. We don't play a role there. It's not used for invasive breast cancer frequently, and it can be used by the NCCN guidelines in any stage to solve problems. When we have equivocal findings on CT, on MRI, on bone scans, we can resort to PET to solve these problems. This is the position of the NCCN guidelines. All cases of inflammatory breast cancer must go through PET scans, because you always find surprises. You always find you always find lymph nodes or distant metastatic cases. And on the other hand, lobular breast cancer is not FDG avid. So you can miss it on PET scan. And an FDG PET scan cannot solve the problem of lobular breast cancer in terms of staging, or cannot help you actually better understand the metastatic disease of breast cancer. Now, if you're doing PET scan for breast cancer in your institute, I always recommend you to do it in the prone position, the same position you do it for MRI. This will help shred the disease, and this will help you tell the multicentricity of the disease over the multifocality of the disease? It's very important. This is the same patient, and you can see doing the patient in prone position can detect more lesions and helps you identify better the disease. Now, where's the breast cancer in this slide? It was really difficult to identify it. And on a prone scan, it's more easily detectable. This case was last week. Another advantage of the prone PET when you do it is to identify or to better identify whether there is chest wall invasion or cutaneous invasion. As in this case, you can easily tell that there is no chest wall invasion on this case. So, the British people took it one step further and they said, okay, we can use PET to solve problems, but we can use it for other indications. Let me show you one example of solving problems. Now, this patient came to us with a suspicious liver lesion and multiple suspiciously thick bone lesions. They were considered metastatic. Bone scan was negative, so it could be negative because the lesions on CT scan are lytic, so having a negative bone scan would be expected. Now, we did a PET scan for this patient. The liver lesion was not FDG avid. Bone lesions were not FDG avid. As you can see, the disease itself is FDG avid because you have always to see the disease itself before judging its metastatic. The disease itself, the primer, must be avid. But in this case, we detected a left gastric lymph node. So yes, the patient didn't have liver mets, didn't have bone mets, but she had left gastric lymph nodes that were positive. So PET scan not only help solve a problem, but can detect more metastasis. And this is very important in patients with stage 2B breast cancer and more. So most European societies now advise us, if you have a stage 2B breast cancer, go for PET scan. It will change your patient management in more than 30% of cases. And this is also the position of the Italian and the French societies of of oncologies. Now, what else can you detect? Okay, you stage your patient, you solve the problem. Can you get more information from PET scan? Yes. The high SUV, the SUV is the parameter that tells us how avid is the tumor, how strongly it's taking glucose. And it seems that the higher the glucose uptake, the worse the prognosis. It's higher uptake in patients with ER negative, in PR negative, in HER2 doesn't affect glucose uptake, it doesn't affect FDG uptake. It's higher in higher grade and it's higher in triple negative cancers. Actually, few studies have appeared, even a meta-analysis and prospective studies demonstrated that the higher uptake, the higher the SUV can be used as worse prognostic factor. So if you get an SUV that is above 8.5 or 7, expect that your patient is triple negative and your patient is going to do worse than any other patient. So you can split your patient into two categories, good prognosis, bad prognosis, based only on SUV, because it correlates with all other clinical pathological correlates. So the Royal College of Physicians tell us do PET scan when there is HER2 positive disease or in all triple negative cases, in patients with equivocal cases, or in patients where there is a metastasis, but it will be very difficult to assess treatment response in these cases, such as a patient with bone metastasis. You do FDG PET not only not to change the diagnosis, but to you have a tool that will help you in the future to assess disease response. Now, this is how we can assess PET response. Of course, we do it visually, and if I want to talk about disease response on PET, I will have to have at least one lecture, because I have to tell you what is SUV max, what is total lesion glycolysis, what is metabolic tumor volume, and I'm not going through that. But I want to mention one thing. PET is very useful in assessing treatment response at interim cases on the primary disease itself. It's even better than MRI, but at the end of treatment, it's always MRI is the best tool and the most accurate tool to assess treatment response, because PET will be positive frequently due to inflammation post-chemotherapy. And this would limit the utility of PET in these cases. So, Again, it is a problem solver technique. It's for inflammatory, for differential diagnosis of side effects after chemotherapy, such as this case where the plexopathy was suspected after radiation therapy, no on PET, it proved to be a malignant, whereas in this case, it was not plexopathy, it was post-radiation plexopathy because the lesion was not FDG avid. So, FDG PET has many roles in breast cancer, namely staging and prognosis and problem solving. Remember always, the primary has to be hot so as to use the PET for assessment, for better characterization of the tumor. Now what about bone PET? Now bone PET is done by sodium fluoride PET, and it is one of the earliest PET scans available. It is FDA licensed since 1972. Since 1972, it is FDA licensed, but it's not widely spread. Why? Because it has the same clinical value, more or less, as bone scan. Yet, in this same patient, as you can see, this sodium fluoride PET can detect many lesions that are missed on a conventional bone scan. It detects osteoblastic metastasis, and it is more sensitive than FDG PET in detecting bone mets. It's more sensitive than bone scan detecting bone mets. Yet, it is affected by the same limitations of bone scan. There is a flare phenomenon, so you can't use it quite well to identify the presence of bone, to identify the response to treatment, to chemotherapy, because it will flare up. And we, as a nuclear medicine society, physicians are performing always less and less bone scans. Why? Because we are using more FDGs. And FDG PET scans are more sensitive than bone scan detecting metastasis. And they are useful in assessing treatment response. So we usually don't now do bone scans or fluoride sodium PET scans if we did a PET scan and we have proved that there is evidence of bone metastasis on PET scan, on the condition that metastasis is evident on both PET scan and its corresponding CT images. When do you use then sodium fluoride bone scan? We use it when we have sclerotic bone lesions that are suspicious on radiological imaging with negative FDG PET, and we want to make sure that these are not active sclerotic metastatic bone lesions. More important than that, when you have an oligometastatic disease, a single, say, osteoblastic lesion, and it is hot on FDG PET, and you just want to make sure you want to go and target this lesion treatment, you want to give it radiation therapy, you need to make sure that there are no other lesions. That's why you do a sodium fluoride PET in this case. The second tracer that's gaining importance in nuclear medicine that I want you to talk about is Syriana. Syriana is produced by a company that's known as Ionexa. It's an Israeli company, unfortunately, but it has been licensed in the FDA, by the FDA on May the 20th, 2022. And this kind of a tracer can detect estrogen receptor. So you give your patient an IV injection, you do a PET scan for your patient, and you can get an image of the estrogen receptor distribution inside your body, inside the patient's body. This Syriana, by the way, is currently produced for Takhasus Riyadh. So it is available in Saudi Arabia, and we can do it here, even in our hospital. So when to do it? When you want to confirm the presence of estrogen receptor inside a lesion. It is not recommended to do it in lieu of biopsy. So you don't do it instead of the biopsy. You still have to do the biopsy, but it can help you identify the tumor heterogeneity, because you know that there is intratumoral heterogeneity, there is intertumoral heterogeneity, and there is temporal heterogeneity in tumor ER receptor expression, particularly in heavily treated patients. Now, if you compare of course, before FDA approval, its safety and accuracy was tested, and more importantly, its negative predictive value compared to the immunohistochemistry. Look at the number, 100% negative predictive value. So if the ER PET is negative, there are no estrogen receptors, and you can be quite confident about that. If it is positive, then there is an agreement of about 76 or 77% with histopathology. Of course, this depends on the biopsy, where was the biopsy done, and how do you define a positive case. Why do we use it? In which case scenarios do we use ER PET? We use it as a problem solver, because we always face as diagnostic people these three questions. Does this patient have metastasis or not? And is this lesion actually metastasis? Well, it's mildly FDG avid. Is it inflammatory or is this a metastasis? The clinician wants to know. and if the patient has two different primaries, or if you are unable to determine the extent of metastatic disease. And in several papers, the ER PET managed to solve more than 90% of these questions. This is a patient with ankylosing spondylitis. She had a bone scan where bone lesions were seen, but I would say that most of these lesions are degenerative in changes, except maybe that lesion in the left hip. She had neck pain, so she had an ER PET, and the ER PET demonstrates hot lesion in the cervical spine. You would have said that there is nothing, or there is only degenerative changes on a bone scan, but on PET, estradiol PET, you know that this is bone metastasis from breast cancer. And this is the strength of ER PET. The drawback, nothing comes without drawbacks. You see the liver? It's very hot. How can you ever tell that there is metastasis on this liver? So it's good, but it's not good for liver metastasis. Does it have other advantages? Yes, I have told you that FDG PET is not good for lobular breast cancer. Could this tracer solve the problem of lobular breast cancer? It seems that it will add to solve the problem of breast cancer. Very few papers are present in the literature. This paper from 6 prospective studies managed to collect 7 patients with lobular breast cancer who had FDG PET and had estradiol PET without any treatment in between. And in 5 cases, all these 5 cases, the upper row is FES PET and the lower row is FDG PET. You can see that FES PET could detect more lesions than could FDG PET in these lobular breast cancer patients. The other cases, the last 2 cases, no, the FDG PET was worse than the FDG PET because primarily of the presence of liver metastasis. So, does it have other role? Yes, it might even guide us in the treatment, in the management, and in the management of of ER-positive breast cancer. You would use FES PET if you need to measure if how your patient is responding to ER treatment, to anti-ER treatment, if it is good or not, or if the patient is going to respond or not. Now, this is an example. These arrows point to the ER-positive metastatic lesions. Post-fulvestrant, this responded. This lesion did not respond, and this means that this lesion will progress. It does have ER receptor expression, but it's not responding to ER treatment. The second tracer that is coming on, FAPI. FAPI, by the way, we have it in Jordan, they have it in Iraq, they have it in UAE, they have it in Egypt, so I think it's coming here to the market very soon. It's very easy to label, it's a ready-to-use kit, so we will see it in the near future here in Saudi Arabia. What does it image? It images the extracellular matrix. You know better than me that most of the tumor mass is not made of cancer cells, it's made also of fibroblasts. Now on top of these fibroblasts, there's a protein, and this protein is non-fibroblast activation protein. It's a transmembrane protein, it's an enzyme, and this is what we are targeting by FAPI. FAPI is characterized by very high background, very low background, rapid transit. It washes out from background very rapidly. It doesn't go to the brain. That's why it can image brain metastasis, which is a limitation of FDG PET. And lesions detected on FAPI, as this case, are much hotter than lesions detected on FDG PET. It's more sensitive in detecting the primary, and it's more sensitive in detecting the metastasis, particularly in the brain. Look at the target to background ratio between FAPI to the right and FDG to the left. It's amazing. Can it help the problem also of lobular breast cancer? It seems yes. There is no significant difference in the SUV and the uptake value between lobular breast cancer and ductal breast cancer of FAPI. And in this paper published 1 year ago, it seems that patients with lobular breast cancer, negative FDG PET, positive CT scan, you could detect more lesions on FAPI PET in patients with lobular breast cancer. So it seems that our coming tool in imaging lobular breast cancer will be FAPI. The last topic that I want to talk about is HER2 imaging. Everybody here knows about HER, HER2 receptors better than me. I'm the least one to talk about HER2 imaging. But I want to tell you that in nuclear medicine, we are also tackling this problem. We try to image it to help guide your treatment. When we start imaging receptors in nuclear medicine, we always start by antibodies. And antibodies are large molecules. They are very bad for imaging because they give you high background. That's why they try to use zirconium and copper early in imaging of these receptors. We don't use fluor or gallium, which are short-lived radiopharmaceuticals. Zirconium and copper have half-lives of few days, 3 days. This gives us the chance of washing activity from the background. Those people who remember when we started imaging the prostate cancer, we used prostacint initially. It's an antibody. And then we moved from prostacint to PSMA. Now this is what will happen to HER2 imaging. We started by zirconium. And this is how images of the zirconium are obtained. Very high background. After 3 days, you get the image and you get some kind of these images. This is zirconium trastuzumab, PET. This is an FDG PET for the same patient. Most lesions are not HER positive except for that adrenal metastasis. What's happening now is very interesting. This paper was just published a few months ago. They are using now Affibodies. We got rid of the antibody, and we're using now an Affibody, a very small molecule with high affinity to the HER receptors, and we're labeling it with gallium. The next step, maybe it will be labeled with fluor, and it will make it very easy to get the to image, and very high background, very high signal and low background. What they could demonstrate on this, that some patients, let's go back. Some patients, وين رحنا؟ كيف بدنا نرجع؟ كيف بدنا نرجع يا جماعة؟ ما عم بيرجع. Up. هلا. No, this is too much. Okay, some patients, we could demonstrate the presence of ER receptors on imaging despite that these patients on pathology were HER negative or HER low, but we could identify metastasis in many of these lesions that were HER positive. That's how we are going, that's how we are helping the management of these patients. And let me take you through some of the images. Okay, where we are. Here we are. Okay, the upper row, it's a HER2 PET with gallium. You see all positive lesions are HER2 positive. This is the baseline FDG PET. It's almost identical. This patient will respond to HER2 treatment because the patient has HER2 positive metastasis. Now, this patient, on the other hand, has very weak HER2 signal. This arrow is the site of metastasis. This patient has, this is his FDG PET, her FDG PET, and this is after treatment. This patient, you can predict earlier, this patient is not going to respond to HER2 treatment. On the other hand, this patient had mixed appearance between the HER2 PET and the FDG PET. Some lesions, as you can see here, are quite HER2 positive, and this responded to the HER treatment. But some lesions are not HER positive, and these patients and these lesions didn't respond to the HER2 treatment. So, yes, I think in the near future, also it may take a few years, we will be having HER2 receptor imaging PET available to guide the clinician how to guide his treatment. Other tracers that are coming in the cockpit, yes, we will have androgen receptor imaging, we will be having fluorthymidine imaging, and we are even, some researchers are developing the programmed death ligand PD-L1 PET images. So yes, we will be going in the future with the help of nuclear medicine towards personalized patient care, where you can image your patient and know how the distribution of the tumor biologically is inside this patient. So by this I conclude. I hope it's useful. If anybody has questions. اسألي.
Any questions? I have one question. You mentioned that in FAPI we can image the tumors because of the fibroblast present in it. Some tumors, I have two questions in this. Number one, some tumors don't have much desmoplastic reaction, at least radiologically. We see it like some triple negative tumors, we see it well-defined, rounded, no evidence of irregularity or speculated walls. So we're told there's no fibroblastic reaction. So is it possible in these such tumors that FABI may not be sensitive to detect it?
Well, even though most of the tumor cells will be composed of fibroblasts, so yes, it is sensitive, and I think because we still do not understand very well FAPI, we don't understand how it is affected by chemotherapy, how it will be affected by biological treatment. So we still don't understand that. We know that it has a very high target to background ratio. We know that it can be even used for treatment, but we don't understand everything about it. So for the time being, I think what will happen that FDG will be the dominant, and FAPI will be used as a problem solver for those lesions that the FDG PET couldn't, particularly lobular breast cancer and other cancers, the mucinous secreting cancers. And the more interesting thing about FAPI, that because it doesn't go to the brain, it doesn't go good in high quantities to the renal cortex, it will be used as a treatment ligand also. It will be joined to lutetium, and it will be used to treatment. So it is still very useful, even tumors without desmoblastic reaction.
One last question as well. Sometimes in very rare cases, we might find a axillary lymph node pathological or any metastatic lesion that suggests that the primary may be in the breast. But when we do the mammogram or the ultrasound or even the MRI, the background enhancement is very high, especially in young patients, and we cannot be sure which is the real point of problem or the primary here. Can nuclear medicine help us in this aspect, and in which tracer exactly?
Currently, we have the FDG PET and also the FAPI PET. Both of them can be useful in these cases, but more studies are on FDG PET. And we can even do it. There are some dedicated machines for breast PET imaging. They're known as PEM machines. If you don't have PET, you can do also cystometry. We can go back in the years where we used to do scintimammographies. So yes, nuclear medicine can help in that, whether FDG PET or FAPI PET, or if you don't have any, you can go for cystometry PET. It can help you identify which lesion to biopsy. Any more questions? So thank you.
Thank you so much, Dr. Galti. It was a great one.
طبعا we have many questions, but we don't have time. في التيومر بورد أسألك إياها. So let's في ميكروفون هذا شغال. Let's move on, Ali, to the next session. مين معك في
Yes, without further ado, we'll start it immediately. I hope you are still awake. The last session will be handled by medical oncology. Yes, Dr. Samer. Yes, we will start now. We will talk about the metastatic HER2 breast cancer and the early setting, with some focusing about the brain mets. We have the first one, Dr. Ahmed Al-Faraj. This is my pleasure to present you his senior medical oncology consultant working King Fahd Specialist Hospital in breast cancer. So we will talk about the early HER2 breast cancer without any further ado. Yes, mic for you.
Thank you, Dr. Ali. Thank you, Dr. Ali. I'm so short, so I have to use the... Okay. I have been tasked to talk about early breast cancer, early HER2 positive breast cancer. And this is the outline of my presentation. I'm going to be tackling the stage 2 and 3 and talk about the role of anthracycline in the treatments, role of pertuzumab, and then how do we tackle patient treated with residual disease if they are treated preoperatively, and then what do we have a further treatment to improve outcome, and then I'll tackle the early stage, very early stage, stage 1 HER2 positive, mainly focusing in APT and attempt trial, and I'll give a final algorithm for the treatments of early HER2 positive. The question is that what is the best combination of chemotherapy that we use in treating HER2 positive disease, and can we replace or substitute anthracycline by taxane or other combination? And I think is because of the overlapping toxicity, people have thought about the topic early on. That has been seen in the Breast Cancer International Research Group, the 006, which was published and presented by Dennis Sleiman, in which the first clinical trial randomized patient between TCH, which is docetaxel, carboplatin, Herceptin, versus ACTH in the treatment of HER2 positive. And although this clinical trial is not, statistically powered to differentiate, between the two treating arm, but it have given us a very important clue that, all the parameter, the disease-free survival, overall survival, and even the highest risk group of patients treated is, you see there is no difference between the ACTH versus TCH. They look similar, and what is being noted is that the ACTH, or the anthracycline-containing arm, has much higher cardiac toxicity, as well as higher numerical number of secondary leukemia. The second clinical trial that has been tested the idea if we can replace anthracycline came in the new era, in which the TRAIN clinical trial that randomized patient between paclitaxel, carboplatin, trastuzumab, bortuzumab, 9 cycle, although this is a very unconventional and have given much treatment than what we usually use for early stage HER2 positive. And in the control arm is 3 cycles of FEC followed by 6 cycles of again, this is non-conventional, but it have reached almost into the same conclusion that the anthracycline arm does not add any advantage, at least in the complete pathological response, where you see the 2 arms look the same. The same things for event-free survival. If you look into the event-free survival look the same. There is no difference between the 2 arms. So in these 2 clinical trials, anthracycline does not add anything, neither in event-free survival, complete pathological response, even with the highest risk group, which have higher lymph nodes, they don't behave differently. And I think because of the higher toxicity in the anthracycline arms and the higher numerical number of leukemia, and even in the TRAIN 2 clinical trial, more even for prime neutropenia, I think people become convinced that anthracycline has to be omitted from the treatment of HER2 positive, and this has been adopted by most of the oncologists. As we know now, the treatment is, I'm struggling with changing the, So based in these two clinical trials, I think as we know, I mean, there are very few people who use anthracycline except in area where the financial, I mean, social or financial statuses do not allow them to give the patient the standard of care, which is most of the times around combinations of anti-HER2 with probably taxane and carboplatin. Can we add any, benefit out of the use of bortezomib to the Herceptin? This have came, from combining the early preoperative trial, both the NewSphere, the Trifina, reported adding bortezomib increase the chance of complete pathological response, even for those groups with higher number of lymph node involvement. As you see, in the NewSphere as well as Trifina, the number of complete pathological response increases as you add bortezomib. This as well has been noted in the adjuvant clinical trial, the Affinity, in which the addition of bortezomib to trastuzumab and chemotherapy have led into improvement in event-free survival when the first, interim analysis reported, it showed that there are 2.5% delta between the arm of bortezomib. Adding bortezomib increase your disease-free survival and relapse-free survival. The same thing as well, the number of complete pathological response. The patient, even for patient with a high, this improvement was noted mainly for the node positive. When the trial did second interim analysis after 8 years, it was noted that the overall survival is not any difference, but the invasive disease-free survival, there is a delta of 2%, mainly in the node positive. This is after 8 years of interim analysis. When the exploratory analysis is done, it was clearly found that those with node negative do not benefit out of adding bortezomib, while the benefit mainly overall survival of 2% and 5% in invasive disease-free survival is restricted to the group of patients with lymph node involvement. So, bortezomib definitely improved the outcome, but mainly for adding bortezomib, mainly for patients who are node positive. We know as well, ER positive or triple positive, ER or hormonal HER2 positive tend to behave, better, and they do well. In the first interim analysis, we noted that the ER positive did not benefit from adding bortezomib. But second lesson that we learn out of this clinical trial, that we do not rely in the early analysis. As you see, when the data mature, you see in a higher, after 8 years of analysis, data collections, you see that the ER positive tend to have a later events, and you see that the event-free survival, invasive disease is as good in hormonal positive as well as in ER negative. So it's not restricted to, ER negative only. So when should we use pertuzumab? I think is for every patient with larger tumor, particularly those more than 2 centimeters, or those with positive lymph nodes. Are we over-treating patient when we give patient based in only size? Probably yes, but I don't think it's, there is any way of becoming certain whether the node get involved in the treatment of patient neoadjuvantly. So since pertuzumab has been used in the adjuvant and showed, some improvement for those with positive lymph node in the early neoadjuvant clinical trial, I think pertuzumab should be added for all patients for stage 2 and 3, even if the node is not positive. If patient achieve complete pathological response, should we omit pertuzumab? We do not have any data to suggest, to address that particular point. So we probably will give everybody who achieve complete pathological response 1 year of trastuzumab and pertuzumab, even if we would have to treat patients who are having, say, 3 centimeter lymph node is negative, but there is no way of to discern, if the lymph node is involved or not involved preoperatively, and you will never be certain. So we tend to give everybody more than 2 centimeter or node positive dual anti-HER2. Those who did not achieve complete pathological response, we usually treat them with the Catherine clinical trial protocol, which patients who do have residual disease tend to be treated with T-DM1. Those who achieve complete pathological response will continue a 1 year trastuzumab and pertuzumab. The early analysis showed that adding T-DM1 improve invasive disease-free survival by 50% and the overall survival as well, with a delta of 4% for overall survival. Do we treat every patient with residual disease with T-DM1? As you see from the first plots, every patient, irrespective of what is the amount of residual disease, even for those with tiny micrometastatic disease, tend to behave better with T-DM1 versus trastuzumab. As you see here, after 8 years or 10 years of follow-up, you see the improvement in invasive disease-free survival by adding T-DM1 with a hazard ratio of 0.54 with a delta of around 14%. Again, all the predefined subset benefit from adding T-DM1 over trastuzumab. See, T-DM1 tend to improve every parameter, invasive disease-free survival, distant recurrence, local regional recurrence, contralateral recurrence, all better with the use of T-DM1. The only site which have higher recurrence than the trastuzumab is the CNS metastasis, which indicate that probably TDM1 does not work in a patient who does not have a broken blood-brain barrier. But we know that TDM1 work for patients with brain mets, but it does not prevent brain mets. How about those patients who have a residual disease that have changed their phenotype? Instead of having positive HER2, do they get benefit out of adding TDM1? This is only an exploratory analysis that has been done in Catherine. There are 70 patients who are being treated, and then upon retesting, they found to have HER2 negative. There are 28 patients treated with TDM1. None of them recur. The rest of the 70 patients, which are, were in the trastuzumab arm, there were 11 patients recur. So probably TDM1, even if patient change its phenotype from HER2 positive to HER2 negative, will probably benefit out of given TDM1 for 1 year irrespective. So this is the final, or second overall survival analysis that showed TDM1 superior to the trastuzumab with a hazard ratio of 0.66. What can we do to improve the outcome in patients who are having residual disease? I think is the COMPASS HER2 RD is one way of testing whether adding tucatinib to TDM1 may improve the invasive disease-free survival, or at least reduce the risk of CNS recurrence. And we are waiting for the result to be reported. Another clinical trial that are being tested now is that comparing TDXD versus TDM1 in Destiny-03. Even the use of a new adjuvant before TCHP, TDXD for HER2 positive in Destiny-11 or 13. 11, I think, yes, Destiny Breast 11, yes. So these are one ways of trying to improve the outcome in patients who have residual disease beyond TDM1. How about the earlier stage, which is stage 1? How frequent do we see stage 1 in HER2 positive? The ER or triple positive is being reported in 40, as per SER database, 41% present with triple positive and 34% present with HER2 positive, ER, PR negative. So it's not a small percentage, it's almost 1/3 of the population present. That is not what we see in Saudi Arabia. I think this has something to do with early screening, early detections. That's why stage 1 is more common encounter in clinical practice. What happened to this early stage HER2 positive if they are treated or they are not treated at all? The HER2 positive tend to behave more aggressively and have worse prognosis. So we need to treat, but not all. Not all. This is the MD Anderson clinic, data that showed HER2 positive, they are not treated. 5-year survival is 77%. The NCCN series is 83%. So HER2 positive tend to behave differently if they are not treated with chemotherapy only, not with HER2 positive. The standard of care nowadays, I think this is the ABT trial, given paclitaxel for 3 months and 1 year trastuzumab for those patients with stage 1, whether it is T1B or T1C. But remember that you don't rely in a clinical node negative. For in stage 1, probably you may need to do an ultrasound of the axilla to make sure that your node are not involved, and if there is any suspicion, you do an FNA, and if it tends to be positive, it's better for them to be treated pre-operatively so you can optimize their treatments according to their response to the new adjuvant therapy. But you do not need to treat all patients if they are being screened, and radiologists believe that nodes are not involved. Up to 2 centimeter need to be treated with ABT comfortably. I think is based in the Dana-Farber Cancer Institute data, when they have examined all those who has been referred as node negative, 25% of the patient with at least T1C tend to have a lymph node positivity. That is why you do not have to rely in a clinical examination alone. The result of the ABT trial or paclitaxel trastuzumab is significant. Over the last 10 years, only 6 patients relapse. So you have an invasive disease-free survival at 10 years of 96%. So it's an excellent result, and it's probably should be the standard treatment for at least T1B, T1C patient. Although the ABT included some patient with 3 centimeter, but anything above 2 centimeter has to be treated with the with the TCHB 6 cycles and subsequently treated according to their response to the treatment. This is the invasive disease-free survival result and relapse-free interval. Is there any other option? This is the ATTEMPT trial, which have tested 1 year of TDM1 versus the ABT protocol or TH, and showed similar excellent results in 5 years with relapse-free of almost 98% at 5 years. But unfortunately, TDM1 for 1 year is not easy treatments. And there were at least 20% who discontinued the treatment because of toxicity, for variable toxicity. Some are related to thrombocytopenia, some are related to liver abnormalities and fatigue. So because of the rate of toxicity and discontinuation rates, I think is now there are ongoing clinical trial, the ATTEMPT 2.0, which gives only TDM1 for 6 cycles, which is 18 weeks, then followed by a completion of 1 year of anti-HER2 therapy, ongoing, not yet been reported, but I think the option for stage 1 disease is either paclitaxel, Herceptin for 1 year, or TDM1 for 1 year, but that tend to be more toxic. This is the 5 years invasive disease and relapse-free interval that I've talked about. And these are the toxicity and the rate of discontinuation rates in the TDM1 in ATTEMPT trial. So based in this, because of the toxicity, I think is we can try for those who are younger and who are willing to accept, but the data are more mature with the ABT clinical trial. This is for those with a T1A. If they are ER positive, you can skip the treatment altogether and treat them with hormonal therapy alone. For those patients with T1A that have higher risk features, such as high grade or lymphovascular invasion, probably need to be treated with either the ABT protocol, or the TDM1. For T1B and T1C, all after assessing their axilla need to be treated with some anti-HER2 therapy of some sort. And this is the Dana-Farber Institute data when they have done upfront surgery for those who tend to have node negative. As you see here, the 1C almost 24.7% having positivity. So the algorithm is that any patient who present with a tumor more than 2 centimeters or node positive has to be treated with 6 cycles of TCHB. If they have complete pathological response, they continue with Herceptin, pertuzumab for 1 year. If they have residual disease, you shift them to TDM1. For patient with from 1 to 2 centimeter or T1C, they need to have an axillary ultrasound. If they have a suspicious lymph node, they need to be biopsied. If it turns to be positive, you shift them to TCHB. If they are negative, you can take them to upfront surgery. And then you treat them with either paclitaxel, Herceptin for 1 year, with a 3-month paclitaxel, or TDM1 for 1 year, which is probably very hefty. If they at surgery tend to have lymph node involvement, or they are bigger than what we thought, then they need to go for TCHB. With this, I would like to conclude and thank you for your attention.
Hello. Yeah. Thank you, Dr. Ahmed. It's always great to listen to you. I was just saying, I think you're the only one who, in the Eastern Province, practicing oncology older than me. So.
Well, don't tell them how old I am.
Next, we have, thank you. We'll keep questions to the end, I guess. Next, we have Dr. Hashim Al-Hashim. He's a medical oncologist and head of medical oncology at King Saud University and works at King Khalid also hospital. Dr. Hashim, he will be talking to us about metastatic breast cancer, HER2 positive beyond first line.
So, do we have another mic? Thank you, Mr. Chairman, and thank you for Al-Moosa Health Group and Dr. Ahmed Lubari for the invitations and for the hospitality for this events, and I congratulate them for the success of such events. So I will talk about HER2 positive metastatic breast cancer beyond first line. So this is my disclosure. So I will give brief introductions, then I will talk about the approved by FDA and NCCN guidelines, the current guidelines, and we'll talk a little bit about what is the future directions and what is the recent updates. Okay, so as we know, that breast cancer is the most common malignancy and is the 5th most common cause of death worldwide. And Saudi Arabia is no exceptions, as we can see here. This is the latest statistics in 2019. We have 2020 also statistics, which is exactly the same. This is the breast cancer incidence in Saudi Arabia. And as we can see, it has doubled in the last 10 years. And I can say with confidence, it is more increasing and increasing. So worldwide, there is 15% of patients are HER2 positive. And we know HER2 gene amplifications overexpressed is linked to more aggressive phenotype and is validated therapeutic target. So do you have the same data in Saudi Arabia? No, we have different data. So this is from 3 different hospitals, from 2 academic institutions and from 1 referral hospital, King Khalid University Hospital, King Faisal Hospital in Dammam, and from Jeddah University. As you can see, HER2 represent from 23 to 27% compared to 15%. And this is how we define HER2 positivity by immunohistochemistry, 3+ or 2+ with positive FISH. And this is just the slides as shown this morning by Dr. Miral. So till now, we have 8 FDA-approved medications for HER2 positive. We have 3 monoclonal antibody, 3 tyrosine kinase inhibitor, and 2 antibody drug conjugate with different mechanism of action. This is the proposed algorithm for treatment of HER2 positive metastatic breast cancer. Though the sequence beyond second line is still not well known. And this is the NCCN guidelines. It is matching the ISMO guidelines with the first line is Cleopatra trial, as all we know, as all of us knows, which shows that there is improvement of both progression-free survival and overall survival with a long follow-up of more than 8 years. And this is the standard since more than 13 or 14 years till now. What is after Cleopatra? So if patient progressed after Cleopatra, so for more than a decade now, for more than a decade till recently, TDM1 was the standard of care based on Emilia trial and Theresa trial, which shows improvement of overall survival. More recently, we have TDXD, which shows in Destiny Breast 01 trial objective response rate of 62%. And all of these patients received the prior trastuzumab and TDM1. So what is TDXD? TDXD is antibody drug conjugate and has different characteristics than TDM1, mainly in the payload, which is topoisomerase 1 inhibitor with drug-to-antibody ratio 8:1 compared to 3.5 to 1 in TDM1. And has a cleavable linker compared to TDM1 and has evidence of bystander anti-tumor effects. So the TDXD was studied head-to-head to TDM1 on the Destiny Breast 03. All the patients, they received the previous trastuzumab and taxane in metastatic setting or neoadjuvant setting and progressed less than 6 months in the neoadjuvant setting. 1-to-1 randomization to TDXD versus TDM1 with primary endpoint progression-free survival and secondary endpoint overall survival. This is the brief summary for the demographics. As you can see here, 50% of patients are hormone receptor positive, 15% has baseline metastasis, 70% has visceral disease, 61% receive prior pertuzumab and median 2 lines of prior therapy. Clearly, we can see here there is improvement of progression-free survival with hazard ratio 0.33 with significant p-value. And also, there is improvement of overall survival with hazard ratio 0.64 with significant p-value. And the benefit is consistent in all the subgroups. This is the safety profile, and the rate of drug-related grade 3 and more were similar in both arms, with the most common drug-related adverse effects associated with discontinuation is pneumonitis in TDXD, and it reaches up to 15.2% in TDXD arm. What is after TDXD? So for patients who did not receive TDXD in the second line setting, we have the initial trial, which is DESTINY-Breast02 trial, which compared TDXD versus treatment of physician choice, which shows positive result of progression-free survival with hazard ratio of 0.35 and overall survival with hazard ratio 0.65. So if patient did not receive TDXD in the second line, so it is an option in third line and beyond based on DESTINY-Breast02. And we know that the TDXD resistant does not mean resistant to all anti-HER2 therapy, but is resistant to DXD part, but still these patients are sensitive to TDM1 and to catinib. And this led us to HER2CLIMB trial, which randomized patient to trastuzumab capecitabine versus this combination in addition to catinib, with primary endpoint is progression-free survival. And clearly we can see that hazard ratio is positive, 0.57, with significant p-value into catinib combination arm. And also there is improvement of overall survival with hazard ratio 0.73. I will not talk in details about brain metastasis, as will be covered by Dr. Bassam Basleiman in the next lecture or next presentation, but we can see clearly here that overall survival is improved in patients received two catinib combinations with a hazard ratio 0.6 and almost doubled from 12.5 months to 21.6 months. And the intercranial response rates more than doubled from 20% to 47.5%. The most common adverse events are diarrhea, hand-foot syndrome, and nausea, as we know from the tucatinib combinations. What about later lines of therapy in patients with HER2-positive metastatic breast cancer? So we have NALA trial, which is a patient who previously treated with more than 2 lines of HER2-targeted therapy, metastatic breast cancer, randomized to labetinib capecitabine or neratinib capecitabine with primary endpoint overall survival with secondary endpoint progression-free survivals. And we can see here that the primary endpoint, so it has a dual primary endpoint, PFS or OS, and either one is reached is positive. And we can see here the primary endpoint for progression-free survival is significant with improvement from 6.6 to 8.8 with significant p-value, but there is no improvement in overall survival. What other options we have? We have mirgatuximab, which has different mechanism of actions. So mirgatuximab is different than TDM1 as it's increased the affinity of activating CD16A and decreased affinity of CD32B. And it is studied in SOPHIA trial, which randomized patient to trastuzumab chemotherapy combinations versus mirgatuximab chemotherapy combinations, we showed improvement of mirgatuximab combination therapy with hazard ratio 0.7 with significant p-value. And it is approved as subsequent lines of therapy. So what is the recent update we have from the recent San Antonio and other meetings? So there is a lot are coming in the pipelines, and a lot of phase 3 trials, either in the subsequent lines of therapy or even in the adjuvant, neoadjuvant setting. In the second line setting, we have HER2CLIMB-2 trial, which compared TDM1 to TDM1 with combinations with tucatinib in 1-to-1 randomization in a double-blinded phase 3 trial with primary endpoint progression-free survival with a number of secondary endpoints, including overall survival and others. As we can see here, in the baseline characteristics, there is 44% of patients in this trial, they have brain metastases, either active or treated or stable brain metastases. And the median lines of prior therapy are 1 line. So it's basically second line trials. And as you can see here, there is improvement of progression-free survival from 7.4 months to 9.5 months with a hazard ratio of 0.76 with significant p-value, but it is negative for overall survival. The most common grade 3 toxicity of TDM1 combinations are hepatotoxicity with increasing of ALT and AST. So in conclusions, there is multiple lines of concurrent chemotherapy with HER2-directed therapy offers clinical benefit for patients with recurrent HER2-positive metastatic breast cancer, but optimal sequences is not known. And in the slide here, the proposed sequences for patients with metastatic breast cancer based on ISMO recommendations, and they classify patients either to CNS metastasis or no CNS metastasis. And by here, I will conclude, and thank you very much.
Okay, thank you, Dr. Hashim Al-Hashim, for your excellent presentation. We'll leave the question for the end. So I'm going to present my friend and dear colleague, Dr. Bassam Bousleiman. He's a consultant medical oncology at King Fahd Medical City. So he'll talk about the brain metastasis. So Dr. Bassam, the floor is yours. And HER2-positive brain metastasis.
Yeah, thanks, Dr. Sadel, for introduction, and thanks for inviting me. It will be my pleasure to be here today. And I would like to congratulate Dr. Rubari for this successful educational meeting. So I'm supposed to talk about, after now, Dr. Al-Faraj and Prof. Al-Faraj and Dr. Hashim about HER2, and specifically for patients with brain metastasis. So my presentation will not that be long, but I will make it more interesting, but I will present it as a case-based here. So initially, that breast cancer with brain metastasis is one of the challenges that we are facing in our clinic, that once we have a patient with brain metastasis, we know that these patients had a poor prognosis, and most of our therapies is maybe not working, and because the blood-brain barrier. So the incidence of happening this brain metastasis and breast cancer, mainly with patients with HER2 positive and triple negative. It's represent 30% in HER2 positive and 50% in triple negative. And the blood-brain barrier, as you can see here in the diagram on the left side, you can see the blood-brain barrier. It's important it's limiting the cytotoxic medication through the efflux pump available in the brain and endothelium. And most of the clinical trials for more than 5 years from now, most of clinical trials, they are excluding the patient with brain metastasis from enrollment. Till recently that we have maybe 2 or 3 basic clinical trials, phase 2, 3, and 2, they start to be enrolling patients with active brain metastasis and make it specifically for patients with brain metastasis. Here, the incidence of brain metastasis in HER2-positive breast cancer, we can see it's around 20% in the first line, but it starts to be increasing with the second and third and fourth, reaching to 36% in patients with HER2-positive. Here is from registered data. It's retrospective data from they collect all the patients with HER2-positive, and we can see here from this data that the survival of these patients with HER2-positive metastatic breast cancer, it's around 12 months. But they categorize the patient to 2 categories: patient with de novo and patient who had recurrence. So we can see the patient with de novo at metastatic breast cancer, whose the initial presentation has a CNS. We can see that here it's the survival for them is around 22 months. I mean, the median survival is around 20 months, and the patient who had a recurrence is around 10 months. So this is the case that I would like to share it with you. It's around this present to me in October 2019. She's a 37 years old lady diagnosed with locally advanced HER2-positive breast cancer. We started initially on a neoadjuvant trifina protocol, and after that she had the mastectomy. The pathology after the chemotherapy, it showed there is a residual disease. That's why we offer for her TDM1. She received it for 4 cycles, but she had neuropathy. She cannot tolerate the continuation or the dose reduction, so we switched her back to bertuzumab, trastuzumab. And he completed on January 2021 the maintenance dose of bertuzumab to trastuzumab. After 9 months from completing the maintenance therapy, she presented to the clinic with headache associated with imbalance in walking. For that, we requested the MRI, which showed a single left cerebellum lesion around 1.2 centimeter with no other brain mets. And the restaging systemic disease, they found there's multiple pulmonary nodules mainly in the lung. So what's the initial presentation of brain metastasis? Is it all the time is headache? No. The brain metastasis can present from many things, ranging from subtle symptoms to extreme symptoms. So what's the subtle symptoms? We can say like patient had difficulty in finding the word, patient had a challenge in handwriting. Also the common one is the headache, nausea, motor weakness. And the extreme that it could happen that it present to the emergency, but with seizures or intracranial pressures. Is there a way to define who's this patient? The only thing that we know that the patient with triple negative and HER2 positive, this is the highest risk for brain metastasis. So we are expecting to have these, once they have any mild symptom from these, we have to request a breast brain imaging, brain MRI, the gold standard for brain metastasis. Unfortunately, we don't have any current guideline to perform a routine surveillance with brain metastasis in this population of patients who had high risk of brain metastasis. And at the same time, no recommendation to avoid the screening. So the recommendation is make it free for the physician as a physician judgment. Once there is a patient with vague symptoms, he can request the MRIs to diagnose the brain metastasis. The brain metastasis radiologically can be present as solitary, necrotic, or solid. It can present with multiple plus minus hemorrhage, or can happen rarely as a dural or leptomeningeal disease. The first thing about brain metastasis is to think about local treatment and should be discussed for any patient with brain metastasis in multidisciplinary meeting with a surgeon, with a radiation oncologist. So this is a decision, it's not easy task nowadays with the new era of systemic therapy that I will discuss it with you now. So what's the local therapy that we have in the initial treatment for breast cancer brain metastasis? We can either local treatment is the most important for brain metastasis, and mainly the radiation therapy, which is the backbone for this patient. The surgery is rarely to be done, and specifically for specific indication, like if patient has presenting with large symptomatic tumors, and mainly by patient with limited disease, or patient who had failed the radiation therapy, who are progressing after the radiation therapy, so as a post-salvage. And lastly, is for rare situations that when we want to do the diagnosis, like distinguishing the progression versus radiation necrosis. So here is this is the data comparing, showing the benefit of adding the surgery with the stereotactic radiation. As you can see here, that adding the resection with the radiation is improving the survival for patients with brain metastasis, reaching to 40 weeks versus no surgery to be 15 weeks. Also, another data here in the down, it improved the local progression-free survival and the overall survival 10 months versus 6 months. But these specifically for patients with good prognosis. But for patients with poor prognosis who has the KBS less than 60, the benefit is less here. What about radiation? Radiation, we have two things. There are whole brain radiation, which is take more time and had a more acute and long-term toxicity. And it's treating the visible and the microscopic disease. On the other side, we have the stereotactic radiosurgery, which has a high local control rate at the lesions and less toxicity to the brain. This is the recommendation guideline from ESMO, published in 2021. We can see here that, and they publish it specifically for patients with brain mets, so and HER2 positive, and they have patient good prognosis with local approach. They make it here for absent extracranial surgery or SRS for patients with single small inaccessible lesion SRS. Were limited number, and they didn't define the numbers. They said up to 4 SRS, and with extensive large lesions to be whole brain radiation. And for patients who had a systemic, and this patient who had, other than the local approach, the systemic approach here, they define it for the brain metastasis. For patients who had no extracranial disease, and there is only isolated CNS approach, we can see here it's, sorry. Yeah, we can see that patient who had no systemic disease and only the brain metastasis, we can treat it locally and continue with the same systemic therapy, pertuzumab and trastuzumab as a first line. But, and for patients who are repetitive progressing on the pertuzumab, trastuzumab, and they have systemic disease, they're recommending either tucatinib or TDXD. So coming back to our patient, so she received a stereotactic radiation therapy to the brain, and because of the systemic disease, we start resume, and she had off treatment around 9 months. We resumed the chemotherapy, paclitaxel with pertuzumab and trastuzumab, and she had good response on that systemically, and she continued on maintenance pertuzumab and trastuzumab. After 9 months, again, present with progression as you can see here in the imaging, there is multiple brain mets. There is a significant number in the lesions, more than 4 lesions. But the CT scan, once we do it for the systemic disease, there is no systemic disease. We have only multiple brain mets after 9 months on maintenance pertuzumab, trastuzumab. So at that time, I didn't have an access to TDXD or tucatinib. So I followed the guidelines to continue pertuzumab, and we offer whole brain radiation. So what's the data for the continuing pertuzumab, trastuzumab, the systemic therapy? If there is only solitary progression in the brain and no systemic disease, there is only few published evidence. There is no good data. The only data that we found is about a data phase 2 trial is called Camellia. It's they include a retrospective analysis from 270 patients who had progression on TDM1. And for 70 patients who had no systemic disease progression, they allow for continuing on TDM1, and they found here, they found that the patient on TDM1 has around 6.2 progression-free survival. Another data is from HER2CLIMB data. In the subgroup analysis, they include the 30 patients who had isolated brain metastasis. They treated locally, and they continue on tucatinib without changing. And for the isolated brain progression, they found that there is no systemic resistance. So we can see here in the diagram for this isolated brain metastasis and no systemic disease that tucatinib it showed continuing in efficacy even after progression in the brain. So unfortunately, we continued the bertotrastu for 3 months. But the patient had more increase in the progression systemic disease in the lungs. So after 3 months, while she's on pertuzumab, trastuzumab. So coming now for what the available systemic therapy that we have. We have multiple strategies in HER2. We have the antibody drug conjugate. We have the TKIs. I will speak only on 2 of them, the tucatinib and TDM1, because Dr. Hashim already speak in detail about them. And specifically, I will speak about the brain mets. The first thing is the tucatinib. You can see from the HER2CLIMB trial, they include around 600 patients, 40 of them associated with brain metastasis. And this trial, once they compare tucatinib versus trastuzumab with capecitabine, And they defined the patient with brain metastasis into two groups. Patient with a stable disease who is treated with local modality and non-progressive, and patient who had active brain metastasis. What's mean by active? Patient who had untreated, asymptomatic, or treated with local modality but progressing on this local modality. So this is the two main definition for the AST. So they include around 290 patients with brain metastasis out of 600. For stable brain metastasis, around 117 who treated at that time and no progression. And for active brain metastasis, who had progression after previous treatment, around 100 patients, and the untreated is around 66 patients. And once we look for this specific patient with brain metastasis, we can see here that the efficacy of tucatinib with combining with trastuzumab and capecitabine, that the overall survival is improved after 2 years of follow-up. Also, once we see the intracranial progression-free survival is improved, as you can see here, 9 months versus 4 months. And the last endpoint that it's also important to be seen is progression of a new brain metastasis. Using the tucatinib here, we can see that it's free of brain lesions for 25 months versus 13 months in the patient who had capecitabine with trastuzumab alone. This is a study. It's to assessing the role of continuing tucatinib after patient. So they include the patient who had patient who had isolated brain metastasis with no systemic disease, and they treated locally with radiation or surgery or stereotactic radiation, and they randomized them to either trastuzumab, pertuzumab with tucatinib, or changing to antibody drug conjugate with tucatinib, the TDM1 with tucatinib. And this is it's still, they are ongoing the trial. I think this is the answer, the question of continuing tucatinib on this patient who had progression in the brain with no systemic disease. Second medication is about trastuzumab deruxtecan. I will skip this slide. Dr. Hashim explained in detail. The most important trial is the Destiny Breast 03. So they randomized the TDXD versus TDM1, and they include 20% of the patients with brain metastasis, but these different population here, they are all stable brain metastasis. They are all treated, not active brain metastasis. And we can see the result was positive for progression-free survival, and once we see for the brain metastasis specifically, the median progression survival for TDXD is 15 months versus 3 months for TDM1. The 12-month progression-free survival 70 versus 20, with hazard ratio statistically significant 0.25. And that's in ESMO 2023, they published this, present this data, which is a retrospective exploratory pooled analysis from all the Destiny's trial, Destiny 01, 02, 03. And they pooled the patient who had TDXD and patient who had non-TDXD, and they defined them to be active brain metastasis and patient who had stable brain metastasis. And so they include all these 3 trials, and they pooled the patient on TDXD with active and untreated brain metastasis. You can see here on the TDXD bone metastasis pool that patient with treated and stable, the response is around 45%, and for the patient with untreated or active brain metastasis is almost the same, it's 45%. So is assuring for us that using TDXD even for active brain metastasis is effective. Once we look for the comparator arm who's using non-TDXD, either systemic therapy or other trastuzumab with chemo, we can see that patients with treated with local therapy is around 27%, and patients who had active brain metastasis with no treatment is around 12%. We can see here, the response, the shrinking in the bone metastasis with TDXD compared to the comparator arm. That is very prominent with the TDXD. Also, one of the important exploratory endpoint is the CNS progression-free survival, that the TDXD is showing prolonging in the CNS progression-free survival in both in the patient with treated and stable brain metastasis and untreated and active brain metastasis, but is more prominent in patients with untreated active brain metastasis. This is small data about the patients with active brain metastases, Tuxedo, Debra, and Duke. All of them, they are assessing the role of TDXD and patients with active brain metastases. All of them, they show a response ranging from 70 to 40%. So all of these data assuring that TDXD have an activity. And last San Antonio, they include, they published this data about patient in Debra trial in cohort 5 for leptomeningeal disease specifically. We know for patients with leptomeningeal disease, the survival for them is only 6 months. They have the poorest prognosis here. And they look for the TDXD for this with leptomeningeal disease. The result of that, they showed the overall survival for this patient with TDXD is reaching 13 months, which is more than a year. We didn't see it before for a patient with leptomeningeal disease. So lastly, the ADC with TKIs, Dr. Hashim already discussed on that, but with HER2CLIMB-2, which is using the tucatinib with TDM1 versus TDM1 alone, they include around 44% of the patients with the brain metastases, and the results showed there is improvement in progression-free survival, and we can see here in the left diagram, even with patients with brain metastases, adding tucatinib to TDM1, there is improvement in the progression-free survival. But the question how to now to choose between these three options, will we use it alone or sequential or use it as a combination? We don't know. I think we have to wait for the result of overall survival. So back to my patient before reaching the conclusion. This patient is, at that time, once progressed, after 3 months of bertuzumab and trastuzumab, we start the TDXD. She continued for more than, after 3 months of starting TDXD, she had a progression in one of the lesions and shrinking in all of the other lesions. So the question at that time, why this lesion is progressing and all the other lesion is shrinking, it's because of radiation necrosis. The only thing to avoid to diagnose radiation necrosis is by taking a biopsy. At that time, I proceed with giving a steroid, but she had a response. The pain is getting better, and I continued on TDXD for more than a year and a half. With almost complete response, there is only mild changes. So last thing about who's the patient will not use local treatment and use the TDXD. This is a guideline from the ASCO for the HER2 positive brain metastasis. They include the 3 criteria: patient with favorable prognosis, patient asymptomatic with a single lesion less than 2 centimeter, or multiple, all of them less than 2 centimeter, who had no symptom at all from mass effect. We can use the HER2 directed therapy like tucatinib or TDXD. So the first line for patients with brain metastasis should be Cleopatra. The second line will be TDXD or tucatinib, and after that you can use any of the anti-HER2 with the chemotherapy. So the conclusion: brain metastasis and HER2 positive breast cancer are common, and the antibody drug conjugate in the brain metastasis is quite well, and also the TKIs. TDXD and tucatinib and capecitabine with trastuzumab are the most active regimen and stable and active HER2 brain metastasis. And be careful for when using the TDXDs with the radiation necrosis. And thank you.
Questions. If
Yeah. Well, thank you. I know I've talked about TCHB is not an easy protocol. There are toxicity, and sometimes people struggle with it, particularly those who are elderly. So you need probably using weekly better, reducing the area under the curve. Maybe, I mean, instead of giving, I usually don't use 6. Most of the people I use 5 for most of the people that I start TCHB. And for elderly, even I use 4.5, 1.5 every week, weekly with paclitaxel rather than, you see that TCHB using docetaxel and docetaxels with carboplatin quite hefty chemotherapy, and a lot of people, particularly those with comorbid disease, elderly, do not tolerate it very well. So you need to reduce the dose, maybe, and give them the weekly, carbopacli rather than dosi carbo every 3 weeks, which is really very hefty. We don't use it. I mean, most of the times is AUC of 5 is enough, and even for elderly, you may give them the weekly 1.5. I mean, so it's going to be 4.5 or. Yeah, I mean.
So there was a discussion last time I told you.
Yes, debate about anthracycline. Yeah, yeah.
There was no question that anthracycline could contribute to carboplatin. Now, in fairness, all of the places that I worked in, no one had given AUC6, not the university, the Jannah. We completed, by the way, the CRTB 4063, we were part of it, the trials struggled with AUC6, and we usually use to AUC of 5 or 4 or whatever they have in the medication side. So AUC6 is not a reasonable, people فبالتالي AUC5 I think is okay. And from personal experience, summer, you would have data to look at the difference. And I would from personal experience with بعد كان مستحيل توصل على اساس المريض بالسؤال انه I really I don't think we under
Yeah, I think is even last year there was some shortage of carboplatin and cisplatin in United States, and there have been a great difficulty for a lot of faculties, very well-known people, in the breast field, whether should we go back to anthracycline. You see a lot of resistance for people to go back to anthracycline because of the overlapping cardiac toxicity, the risk of leukemia. And as you see, although train 2 is not a conventional treatment, that we use usually 6-cycle TCHB. This have used paclitaxel for 6 cycles in one arm with 3 FIC, which is as well is not easy, or 9 cycles. They have seen even more febrile neutropenia with it. So there is no advantage for anthracycline to start with. Although it still, in country where you have no, resources are very limited, people still use anthracycline with trastuzumab and taxane only.
Abu Ali, let's make the things more complicated. And I mean, not dropping only anthracycline, but dropping all the chemotherapy based on Fergain trial, based on PET scan results. So what you are taking from this?
Fergain trial have used the PET scan as a sort of indicator response, achieving complete radiological response to treatment and try to de-escalate. I think it is very complex. Fergain is a very complex clinical trial.
But
it's going to be very difficult to adapt, but it will give you an opportunity to to de-escalate for certain patients, particularly those whom you think likely will encounter a lot of difficulties with the usual TCHB, the full dose. So that will give you an opportunity to reduce and de-escalate and maybe stop for some patients, give them only Herceptin and bortezomib if they achieve complete radiological response based in PET scan, FDG.
Yes, I have one question with Dr. Bassam. About the benefit is not much like that in active. Any order or for upfront TDXD to get the full benefit, avoid local treatment, or you believe that local treatment is make the majority of the benefit in the other hand?
Yeah. Thanks for this question. This result will not change your. It's not comparing TDXD for active or non-active. It's only to show that the TDXD is working for active metastasis and working for patients with stable metastasis. So you cannot conclude from this data, retrospective data, because the number of patients is not equal randomized between the two arms. So it's the only conclusion from this data that it's active, it's working for TDXD. But you cannot say, oh, okay, so that for active brain metastasis, I will recommend for this patient TDXD, and I will not offer the local therapy. So till we have more data about when to use the local therapy, I think we should offer the local therapy for our patient.
Yeah, I think it's for patients who have asymptomatic, brain lesion. Probably certain patients can be treated with anti-HER2 that has been shown to be active, like the HER2 climb protocol. You can, if they have particularly extra. But for isolated brain mets, I think if they have active disease, if they have active or have extracranial disease, probably TDXD would work for both. If they have mainly predominantly intracranial disease, HER2 climb is a more strong data, which is using tucatinib, Xeloda, and Herceptin for those patients because they were enrolled in a prospective clinical trial, in phase 3 clinical trial. Tuxedo is a phase 2 clinical trial. Tuxedo 1, is in 15 patients. Dubra as well in another 15 patients. Data Memorial, Duke, and MD Anderson collection, those are retrospective data. The three clinical center, three of the probably the most heavily involved CNS center treating cancer patient is in these three. That's why the data is so strong, but it is retrospective data. So if you would have to use somebody for active disease, probably use the HER2 climb, particularly if they do not have a lot of extracranial disease.
Thank you very much, Ahmed, for this question. Yes, so as I show in the unpublished data, that resistance to TDXD is not resistance to TDXD all, but only resistance to XD, deruxtecan. But still, these patients are sensitive to TDM1 and to tucatinib. So we don't have phase 3 trial, answer the question, but based on the preclinical data, yes, there is a hypothetical benefit, and based on the retrospective study also and case reports, yes, there is a role for TDM1 after TDXD.
Yeah, I think it's for using antibody drug conjugate after antibody drug conjugate, probably it is preferable if you could use tyrosine kinase in between, because that tend to upregulate the receptor and increase your response to antibody drug conjugate. So if I would probably use some, because they're using antibody after antibody drug conjugate, you might downregulate, particularly either you develop resistance if you have the, payload is the same, or you would have, the receptor is the same. So it's better to be upregulated with a tyrosine kinase and then give them another antibody drug conjugate.
For my patient, it developed within 3 months after starting TDXD. So the first assessment but it's from the retrospective data. There is one from JAMA Oncology. They presented. They include all the patients who had stereotactic radiation in their center. They include around 200 patients, and there is around 50% of the patients they have antibody drug conjugate, either TDM1, TDXD, or SASI. And they found there is the patient who had concurrent stereotactic radiation with the antibody drug conjugate, they have a higher risk of necrosis compared to the half after the concurrent.
Yeah, absolutely. I think is timing of the antibody drug conjugate may increase if it's particularly, with radiation. So, but sometimes you'd have to use.
قصرية معرض التمور ما ندري
انت ما تحتاج تروح.